Insights South End Eye Center, we are starting the OSWB District Outreach Program today. We are very happy to invite all our guests to this program, and we will be starting on time, so it is 9 o'clock. We will first ask Dr. Rotish Chandra to grace the occasion by taking the chairman's seat. Sir, please. Next, I would like to invite Dr. K.P. Ghosh. Sir, please. I would also invite the panelist, Dr. Shubhashish Haldar, to take his seat on the right side of the dais. Sir, Dr. Niloy Mojumdar, please take the panelist seat. President Medal. We would like to first give the President's Medal to Dr. R.C. Pal of the OSWB. Now I would like to call the speakers, Dr. Arnob Pal, to present his case of optic nerve in children. We would request the speakers to stick to their time of 4 minutes. Dr. Arnob Pal, optic nerve in children, please.
Thank you, sir. Good morning to everyone. Today I'll be presenting a case related to optic nerve in children, a case of pediatric papilledema. I am Dr. Arnab Pal, consultant pediatric ophthalmologist. So a 14-year-old girl came to our OPD with dimness of vision in both eyes for the last 1 week with headache and occasional vertigo. There were history of transient visual obscurations. There was an interesting tender swelling at the neck of the child. The physical appearance was obese. Best corrected visual acuity in both eyes was 6/18. The pupils were reacting nicely. The extraocular movements were full in all directions. And on fundus examination, both eyes had papilledema. So basically it was a case of raised ICT, but what was the cause? Whether was it idiopathic or secondary, whether the inflamed neck swelling related to it, whether it was related to TB lymphadenitis, TB meningitis or not. We asked for relevant drug history, there was none. So we referred it to neurologist. He ordered MR venogram of the brain, plain and contrast. He also ordered for blood of CBC, TSH, and he started treatment for migraine. So the MR venogram reports came. So this is basically the top left is a normal. Is there a pointer? Okay, so this is the normal MRI venogram. We can see this is the sigmoid sinus and this is the transverse, lateral transverse sinus. So characteristics of IIH is there is symmetric attenuation or stenosis-like feature of the lateral transverse sinus and the sigmoid sinus which came in this patient. So it was suggestive of idiopathic intracranial hypertension, IIH. However, since no treatment was started, the patient further had decreased vision. The right eye vision decreased to 6/60, left eye to 6/24, The patient was asked to get a CSF manometry and therapeutic CSF drainage as early as possible. The hemoglobin was also less at 6.7 and there was hypothyroidism. So the treatments for this were started. The manometry was done. The opening pressure as expected was more than 40 centimeter of water and 35 ml of CSF was drained. The CSF glucose and protein were normal, basically ruling out any chance of TB meningitis. So basically this is a pediatric IIH in a 14-year-old girl with obese physical appearance along with hypothyroidism and IDA. So the patient was started on, after CSF drainage, the patient improved a lot and she was started on acetazolamide tablet 250 milligram once daily for 1 week. Then the neurologist escalated it to twice daily dosing for the next 3 months, along with regular follow-up of sodium and potassium. The patient came to us at 2 months with better vision, no disc edema. Even at 4 months, after 3 months, the acetazolamide was stopped. After 4 months of start of treatment, the BCVA returned to 6/9 partial with no papilledema, no headache. The hemoglobin and TSH were normal and it was maintained even after 8 months of treatment. So regarding discussion, it is a very rare condition, occurs in 1 lakh children. So basically the revised diagnostic criteria is if the lumbar puncture opening pressure is more than 28 centimeter of water, it affects children of 12 to 17 twice as much as children between 2 to 12, and the patients, the children from 12 to 17 who were affected by it were mostly obese and female. So basically the decreased CSF drainage is the main cause, and the anatomical abnormalities, like I said, transverse sinus narrowing is the main cause. So basically they come either with raised ICP and papilledema, or it might be an incidental finding. Diurnal headaches with migraine, transient visual obscurations, falsely localized cranial nerve palsy, ataxia, paresthesia, this might be the clinical features. Enlarged blind spot, papilledema, and we must rule out pseudopapilledema by autofluorescence. And these are the definite IIH criteria: a bilateral optic nerve swelling with normal neurological examination, normal neuroimaging, normal CSF composition, and elevated LP pressure, which were all present in our patient. The treatment is, as we said, weight loss, acetazolamide, topiramate, and furosemide are additive agents, and surgical management can be done. So basically the take-home message is that we must treat any pediatric papilledema early so that there is no long-term visual loss. Thank you.
Thank you very much. Now I would ask any questions from the audience, please, or for the panelist. Lights on, please.
Hello. Nice case. Actually, I wanted to know about the diagnosis of the neck swelling. What was the cause of that neck swelling? And where was it? Was it a thyroid swelling or something like that?
So it was in the back of the neck.
Back of the neck.
Yeah,
okay.
so unlikely thyroid. But yeah, it was not evaluated by us, or we have not seen any other, even the neurologist had not evaluated for it.
Okay. There is no relation with.
No, it was, there was no relation.
Okay. And next thing is obesity is definitely related to this increase in intracranial tension. So we have to, especially in children, we have to. Is the patient taking any medicine for that obesity?
So patient had lost weight, but the doctor has told not to gain weight again because there will be a chance of
no medicines for
no
that.
medicine as such. No. Okay. Low sodium diet is one of the thing what the doctor has said.
Another thing is when we are advising topiramate, we should always, as an ophthalmologist, should always tell the patient about the side effects of topiramate.
Yes.
Yes.
Absolutely.
Thank you. Thank you,
sir.
Arnab.
Thank you.
Next, I would ask Dr. Deepa Shah to present her case. challenging cataract cases, red flags. All right, ma'am.
I would like to ask one more question.
All right, Devuda, please go ahead.
In
Or
this
no.
case, was there any money? Yes. Fields were repeated later on.
So actually, sir, fields were not repeated.
Not
Our
repeated.
center did not have AP actually, so we did not order for fields. The
What are the-
diagnosis was entirely clinical.
What was the main complaint? Visual complaint was main or headache component was main?
Headache component was main, along with dimness of vision for the last 1 week before the patient came to us.
Okay, so what we'll do if the headache component is more or the visual component is more? What is your plan then?
Sir, if the visual component is more, then definitely clinically there is papilledema. We must go for the other tests also. But since the headache component was also there, the neurologist had started on migraine.
No,
Migraine
I'm talking about management. Ideally, if the visual complaints is more, there is more peripheral constriction of the fields like that, then you will go for optic nerve sheath fenestration. And if it is headache component is more, then definitely you should go for shunt. That is neurologist will, neurosurgeon will do.
So if the conservative management has not
Failed,
treated,
yeah,
failed
yeah,
to treat,
failed.
yes, sir, yes.
Right.
Okay. Thank you, sir.
Thank you. Shall we start the next presentations? Please put off the lights.
Good morning to all of you. I am Dr. Deepa Shaha. I want to wish you a happy Doctor's Day to all of you. Now, my topic of discussion is do's and don'ts in the challenging cataract cases. My first case is a intumescent cataract. I tried Rexis and it was extending. So I want to relieve the interlenticular pressure, but there was Argentina flap sign. But I'm lucky it was very little. So I plan to do the Rexis beyond that tear, and I was successful. This is my second case of fibrotic Rexis. So very difficult. So the principle is wherever you stuck, so you have to cut and go ahead. So here you see there is a fibrotic plaque. So I have to cut and then again pull with the Rexis forceps, but the tear extended. And I have to change my plan, cut the fibrotic plaque and continued SICS. My next case was a simple case, but whenever I used to do the chop, there is a surge. It was a very high-end machine, but I was confused what is happening. Put the viscoelastic, reduce my parameter, and try to chop again. But still, there is a surge again. Now, I don't know what to do. Confusing, put the viscoelastic, increases my main wound, try to separate the nucleus, did the nuclear rotation again, it was freely rotating. You can notice that I have changed the sleeve also, but still, when I again tried the chopping, there is a surge. So the iris integrity was lost and there was a iris prolapse. So the one message I would want to share that however the high-end machine is, we should not be so reluctant. So we should titrate our parameter according to the grade of the nucleus to get a good outcome. My third case is with the pupil. It is a uveitic cataract, 360-degree synechia. So here principle is to release the synechiolisis from both the sides, and the pupil dilatation here was done by the stretch pupilloplasty. This helps a lot in this type of cases. So I did the stretch pupilloplasty and continued my phaco. Next challenge is the intraoperative meiosis. It's a big challenge, and there are so many options out there. But in my case, I prefer to take the help of the iris hook and complete my case. The last challenge is the challenge with the nucleus. It's a posterior polar cataract. The principle is with the low infusion, so it can save the eye. But if there is a PC break, no such maneuver should be done that increases the PCR, and it may lead to a lot of complication. Thank you so much.
Thank you. Any cases, any questions from the audience?
Sir, I just finished it. This was the Centurion machine, and it was my second case in Centurion machine. So initially, I used to work with the very high parameters. The IOP was 70. Then after this case, I realized and discussed with the seniors. Now I am working with 45 IOP. I don't know what happened, but initially 1 or 2 cases, I had to suffer a lot. Easy case making complicated.
No, the surge was happening when she was taking out the probe. That was when the surge was coming.
No, sir. When I was holding, this case was done in AM.
All right.
Okay. So when I was holding, then the surge was occurring, not
All right.
while taking out.
Any obstruction of the flow, fluid flow?
We check the second time. First time when it happened, then we check the second time, same was happening. So
And why did you increase the incision?
uh,
Because
I-
that may induce more surge.
I thought ki there was a mismatch between the sleeve and so, sir, I was confused. So whatever I can do, I increase the incision. Then again, all this, change the sleeve again because incision was bigger than the sleeve. Then I had to again change the sleeve. So, but anyhow, I just completed. The take-home message is whatever the higher end machine is, start with a very, very low parameter, okay? And you just adjust the parameter according to your working comfortability.
As I understand, the surge happens when there is occlusion.
Yes, when
When
I
there is a
was
break in
trying to
occlusion.
hold the nucleus, there was a surge.
So basically, if you don't, to just carry out the case, if you don't make the whole occlusion thing happen, you can, just work your way
Yes,
out
Yes, yes.
in these situations.
Maybe I was in the beginning part of using Centurion. Maybe it's my fault. But the low parameter is very important, what I realized. Thank you.
Thank you, Dr. Shah. Next, we will be going to the next case presentation. Dr. Sneha Jain will be presenting retained intraocular foreign body.
Okay, so I'll just start my presentation. A very good morning to all present here. I'm Dr. Sneha Jain. I'll be presenting a small case. It's of a young male who was referred with a penetrating trauma with an iron projectile, and he came to us almost 10 days after the injury. His vision was around 618, and he had developed a traumatic cataract, and there was also a retained foreign body which was evident on CT scan. So this is just a small surgical video of how I managed the case. So the patient was taken up for surgery. After releasing the synechia which was present, a routine cataract surgery was performed. So the cataract itself was very soft, and it was very easy to devour. The cataract took no time. So just prolapsed it out of the bag and ate up the cataract, following which a good cortical cleanup was done. And there were some membranes on the pupillary margin which was removed to aid in the dilatation of the pupil.
Thank you, sir. Dr. P. Dr. Sombasati. Dr. Sombasati, I will to please do the honors by lighting the lamp. Thank you very much. Dr. Pranapa, Dr. Deepa Shaha. Dr. Sneha Jain. Now we will be having a small birthday party. So can we have the stage? Can we have the cake on the stage, please? Dr. Sombasati Shinmukta to please give the flower bouquet to our birthday boy. Dr. Sholav Shina, happy birthday. Thank you.
We will now move on to the next session. Dr. Roy.
So a very good morning and greetings from Singapore. I would like to thank the organizers for having me here. Nice to see some familiar faces as well. So without further ado, let me go straight to my topic. So I'm going to talk about the infectious keratitis here, which I'm sure that each and everybody in this audience encounter almost on daily basis in your ophthalmic practice. In fact, as a cornea surgeon, we call it a bread and butter of the corneal surgeons, right? So before I go into the main topic, let me talk about a little bit of terminology, what we use in infectious keratitis. So first thing you need to know, what is keratitis? Keratitis is basically inflammation of the cornea. So not necessarily all keratitis is corneal ulcer or infectious keratitis. For example, you have a marginal keratitis or superficial punctator keratitis. These are pure inflammation. There is no infectious component in that. So this is your keratitis. Now, what is microbial or infectious keratitis? So you have to have some kind of proliferation of microorganism, and that is associated with some kind of inflammation. So this is, again, not necessarily a corneal ulcer. So what is a corneal ulcer? So when you say it is a corneal ulcer, then you have the disruption of the corneal epithelium with involvement of the corneal stroma. So these are the three distinct entities that we need to know before we talk about this topic. So we all know that there are some fantastic ocular defense mechanism we have. Not everybody of us get corneal infection because we have fantastic tear film on your eye that has chemicals like lysozyme, immunoglobulins that protect your eye. You have a mechanical defense mechanism like blinking reflex. You have a intact epithelium, which is in fact the first line of defense. Then you have cilia, which protects your eye from the external infection and so on. So let me talk about a little bit of pathogenesis. That means if you have an infection and say you don't treat it, what is the normal or the natural course of this pathogenesis? So you have to have some kind of proliferation of microorganism, which is either closer to your neighborhood of your eye or somewhere else if it is external infection. This infection eventually get to adhere to your compromised corneal epithelium. Then eventually it will go into the stroma. And that is the time your defense mechanism, your body immunity is going to take over, and there'll be migration of the neutrophils. But at the end, at the same time, there'll be some production of the proteinases. These are the destructive material. So there will be some kind of necrosis of the stroma, and eventually the inflammation will progress. There'll be stromal necrosis. If your body immunity is good, if you are lucky, some patients may develop this kind of desmetocele, which is basically the last defense mechanism of the cornea, and eventually your cornea will perforate. So this is the natural progression of the corneal infection if you don't interfere in between, right? So we all know there are some risk factors, extrinsic or external risk factors. You have a contact lens wear, trauma, you have ocular surgery, use of the topical steroids, and so on. You have a local risk factors, like you have a tear film deficiency or dry eyes, you have ectropion, entropion, those are the abnormal leads. You have when you have the recurrent corneal erosion or the neurotrophic conditions, and then you have these systemic risk factors when the patient is severely immunocompromised, like diabetes or HIV infection and so on. So patient comes to you with a corneal infection or infectious keratitis, and this is pretty much everything you need. So this is your 2 slides. This is your slide holder. You have anesthetic drop. You have some needles or butt worker blade or Kimura spatula, whatever you have. Then you have this culture media. So you have an aerobic culture media, that is chocolate and blood agar. You have a Savaras agar media, that is for your fungal, and this is the Robertson Cook media. So this is for anaerobic culture. So what you are going to do, basically, this is all you need for your armamentarium. But if you don't have, if you just want to have just one, probably you get the chocolate agar, which is a enriched agar for your for your aerobic organism, and you have Savaras agar medium. So these are the basically basic 2. But of course, if you are thinking some abnormal infections like those acanthamoeba and so on, you need those kind of special media which you have to arrange in between, right? So once you got those, you do the corneal scraping, and your successful culture basically depends on how much adequate specimen you are getting. So you have a necrotic cornea, and sometimes you get happy that you have so much of a material and you are plating on the cornea. Actually, it is not true. Try to go to the junction of the healthy and unhealthy area where the maximum bacteria has been migrated to eat up those healthy tissues. So your yield will be maximum if you scrape from the junction of the healthy and unhealthy cornea. And of course, you cannot use the antibiotic. I know this is the major problem in India. Most of the patients come to you with some kind of antibiotic used by either general GP or some kind of other ophthalmologist. Do a direct plating. Don't use any transport media, because that will 50% of your yield will be lost. And of course, try to avoid those leads and lashes if you want to have any growth of a commensal or those kind of organism, which is not really your organism that you are looking for. Now, once you have done that, you start your antibiotic, and depending on what kind of antibiotic you are using, your 90% of the patients will recover, right? Either with some kind of corneal scar or some kind of, so you have to think about the next step of rehabilitation, whether patient need glasses, contact lenses, or surgery. So this is your 90% of the patients. But what about those 10% of the patients? These are not the copycat kind of patients you are going to expect. And it is not going to what you are expecting in your normal disease. So I'm going to talk about those 10% of the patients where you have tried everything, patient is going downhill. All right. So you have tried your antibiotics, you have changed your antibiotic according to your culture sensitivity, you have used the traditional treatment, and patient did not improve. So let's talk about 2 cases I'm going to present here. Those are the problem cases. So this is the first case, right? This is a 36-year-old Indian female, came with kind of acute loss of vision, severe pain and photophobia into the eye, and this is what she came with. So if you look here, if you look carefully, this is what the patient has: immune ring, or what we call it, a ring ulcer. Is it really specific? Not really. You can get it in a pseudomonas ulcer, you can get in acanthamoeba keratitis, you can get in a herpes fungal keratitis. So it is not going to give you any information. What else the patient has? You have a stromal infiltrate. Is it really specific? Not really. You can get that in fungal keratitis, you can get in the acanthamoeba keratitis. Mind you, the epithelium is intact here. So this is an infectious keratitis, not corneal ulcer yet. So you look for the other signs. What you look very carefully. Can you see these 2 tiny infiltrate over there in the periphery? That is what I'm looking for. So this is basically what we call it a perineural infiltrate. So this is going to give me kind of, the guide or my guidance, what I'm going to do next. So I'm thinking about acanthamoeba keratitis here. So what I did my traditional scraping. Of course, the epithelium is intact. You have to breach the epithelium to get the deeper tissue. And I plated, in addition to the normal, the culture plates, I plated this on the non-nutrient agar with the E. coli overlay. So this is basically you're thinking acanthamoeba keratitis. I started hourly cefazolin gentamicin. This is the institutional practice in Singapore. We don't give any other antibiotic as a first line of treatment, and that is how we avoid any kind of resistance. I used cycloplegic, and unfortunately, whole Southeast Asia doesn't have a propamidine isothianate. We don't have the the biguanide, polyhexamethyl biguanide. So we normally use the hexamidine and the chlorhexidine for the acanthamoeba keratitis in Singapore. So I started the treatment. So 2 weeks on, the stains are negative, cultures is negative. I'm not getting anything from this corneal scrape. Then surface completely breaks down. There is a patchy infiltrate. There is no hypopyon, and patient started developing kind of intolerance to chlorhexidine. Patient says that is very, very painful, and of course the vision is still hand movement. I continued treatment, and this is 1 month post-op. We are not going anywhere. Patient has a large epithelial defect, deep infiltrate, conjunctiva is heavily toxic, vision is hand movement. Patient still on tremendous pain at this point of time. What are you going to do? 2 months post-treatment, we kind of balanced between chlorhexidine, little bit of steroid in between, and this is what happened in 2 months. I'm just thinking that probably I'm going to win the battle this time. Patient developed this kind of corneal opacity, and although there is a severe corneal vascularization, probably patient is quiescent, probably I can slowly taper off medicine, and probably patient can be okay at this point of time. But this is what patient came back. 13th week post-op, patient came back with a complete epithelial breakdown, and patient has a severe corneal vascularization, no hypopyon, and patient back to the square one. What are you going to do now? So I stopped all the antibiotic for 48 hours. I did another scraping. Unfortunately, no growth, nothing. So there is no guidance at all. This point of time, I decided to go for a corneal biopsy. So we did a corneal biopsy with a skin biopsy punch. The gram stain is negative, culture negative, nutrient agar broth is negative. I am nowhere. What are you going to do next? So what I decided to do is a corneal confocal microscopy, and you see that what they're showing, multiple trophozoites into the stroma. So at this point, at least I'm happy. My primary diagnosis, I'm not wrong. Only problem is that my treatment is not working. So at this point of time, we had a discussion with the patient, and since we told that nothing is working, let's do something out of the box. So we decided to go for a therapeutic deep anterior lamellar keratoplasty. This is 4 months post-presentation. We know this is a fragile cornea. There is a tremendous chance to perforate the cornea. We may end up in penetrating keratoplasty, which could be a disaster to the patient because of the infection and all. So we take that risk and managed to dissect down to the Decimex membrane, and we washed the interface with the hexamidine multiple times, and finally we managed to do that and put a VCL bandage contact lens over the cornea. Post-operatively, I didn't give any steroid for the first 2 weeks. I started with I continued with the hexamidine 4 times a day, slowly started Lotemax or loteprednol, and eventually I increased to the normal level and continued with the levofloxacin and bandage contact lens. I kept it for 1 month. Luckily for me, the patient improved. So this patient is now 5 years post-op. This is not the 5 years photo, but this is 5 years post-op now, not on any medication at this moment, and patient has unaided 6/12 vision. So probably sometime you need to take a risk and just look at the patient's profile and see what you need to do next. Let's go to my last and second patient. This is a 44-year-old Malay female. She is a contact lens wearer, and she works in HR in the front desk job. She came with a extreme photosensitivity, pain, and loss of vision, and patient already used some kind of antibiotic, levofloxacin from the GP before coming to me. Now, I did my usual stuff like corneal scraping. I did a anterior segment OCT. You can see a huge abscess into the stroma. I started my usual treatments with the fortified cefazolin and gentamicin and the cycloplegics. What I got from the scraping, I got two information. My stents give me gram-positive cocci and the septate fungal hyphae. Culture was no growth at all. All right, so at least I have two information. This is a polymicrobial, both bacterial and fungal. So in addition to the cefazolin and gentamicin, I started natamycin hourly. I continued with the cycloplegic and the lubricating drops. If you look at the picture here, the patient is extremely sensitive. Every time I try to take a good anterior segment photo, patient won't allow me to do that. And every time this, the upper eyelid will evert, and I hardly get a good photo in this patient. So 1 month into the treatment, absolutely no improvement with the treatment. I did another ASOCT, and you can see the abscess has gone down even further into the stroma. Patient is extremely symptomatic. So at this point, I decided to stop every antibiotic, all the antibiotic for 48 hours, and decided to do another scraping. And this time I included those, the non-nutrient agar, because patient is on pain. If it is a fungal keratitis, I won't expect so much of pain at least, right? So I plated on non-nutrient agar, but everything came negative. So I'm still with the basic information that this is a polymicrobial. So at this point of time, I decided to go for a multiple stromal puncture, because you know that antifungals doesn't penetrate into the cornea very well. So I thought it might help in the penetration of the cornea, and also discussed with the patient whether the patient want to go for the intrastromal voriconazole, but patient wasn't keen because this is a very, very expensive medicine in Singapore. Patient could not afford. So what next? This is almost 2 months plus, and patient still in the similar state when the patient came in. So what you are going to do next? So at this point of time, I had another discussion with the patient whether the patient want to go for a therapeutic DALC or patient want to go for a corneal cross-linking, because as you know that the corneal cross-linking has some beneficial effect on this kind of recalcitrant kind of patients. So after discussing the pros and cons, looking at the little bit of non-invasive kind of surgery what corneal cross-linking offered, the patient wanted to go for the corneal cross-linking. I went for an accelerated protocol. This patient is severely symptomatic, so I had to go for a peribulbar block. Normally we do cross-linking under topical anesthesia, but we did a accelerated protocol under peribulbar block, and with 4 minutes of UV radiation. Finally, luckily for me, the patient started healing in. I didn't give any steroid for the first 2 weeks, and I continued with the topical antibiotics and epithelium slowly healing in. And in 3 weeks' time, actually epithelium completely healed in. And this is when I started the steroid. This is 3 months post-diagnosis, infection completely resolved. There is significant vascularization. Patient has 660 vision, topical steroid tapered over the weeks. Now, if you look carefully, this patient not only having deep vascularization, patient is developing significant cataract because of the toxicity of those hexamidine and this other medication that we used. So I decided to go for a RGP fitting, contact lens fitting, and patient luckily improved to 612. But this patient works in a HR, human resource, and she's a front desk worker, and she won't accept this kind of look. And neither she want to compromise with her vision. So what is the options left? We decided, we discussed with the patient that if you really want to go for a corneal transplant, this has to be a kind of penetrating keratoplasty. There will be high risk of rejection in considering you are a young patient. At the same time, you have so much of vascularization of the cornea. So probably not a good option since you have a 612 vision, but patient won't budge. So patient wanted to go for something more definitive. If you look at the anterior segment OCT, this is actually going deep down into the stroma. In fact, endothelium, close to the endothelium. So I'm not sure whether DALC is a good option here. I tried to do an endothelial cell count, and it was not possible because of the density of the scar. So after discussion, thinking about the patient age and the vascularization of the cornea, we went to do for a corneal imaging with the pentacam. Patient had very, very flat cornea, which is expected usually in this kind of cases. Patient has a very thin cornea, and we decided to go for a DALC. We wanted to take a risk. So we told the patient that your vision is not going to be optimum. There will be some interface scar, but at least there will be chances of rejection will be low. So this is just 2 weeks, probably 3 weeks by now. We went for a DALC. We managed to go, this is a manual DALC, and we managed to go deep down 150 micron. And what you are seeing here, there's a contact lens on the top. So that's why those are the deposits on the contact lens. So this is the patient at the moment. Patient has 624 unaided at this moment. There is a pre-existing cataract, you know already. So we told the patient that you are basically heading for another surgery soon, probably around 6 to 8 months down the line, and that is going to be a challenge itself. But this is what we have at this moment. So I think that's about it from my side. I leave it here, and thank you for your attention. I'm happy to take any questions if you have.
Thank you, Dr. Roy. Thank you, Dr. Roy.
Thank you.
We'll move on to the next session now. And I would request the chairpersons to come over. Dr. D.N. Chatterjee, sir, and Dr. P.N. Biswas, sir. Sir, please come to the desk for the next session. And this session will be moderated by Dr. Sabyasachi Sengupta and Dr. Debabrata Haldar. And I will request the panelists, Dr. Keshav Haldar, sir, here, and Dr. Arnab Das, Dr. Champakali Biswas, and Dr. Pranab Das.
Good morning, everyone. So we'll get underway with the retina case presentation sessions. Can I request Dr. Arnab Das, who, if you are around, and Dr. Champakali Biswas to be on the podium, please. If the first presenter is ready, you can go ahead with your case of optic disc pit, right?
Yeah.
Shebshan Mohammed, please go ahead.
Good morning. My name is Dr. Shebshan Mohammed. I'm a secondary PGT in the Regional Institute of Ophthalmology, Calcutta. And today I'll be presenting a very interesting case about an optic pit and its management. So basically, a 21-year-old female presented to our OPD with gradual, painless diminution of vision in the right eye since the past 1 year. She had no history of any floaters, metamorphopsia, micropsia, or any photopsia, and there was no history of any pain, redness, or any ocular trauma. Her past history was nothing significant. Personal history, nothing significant. General examination and systemic examination were within normal limits. On the ocular examination, the right eye had a best corrected visual acuity of 6/60, and the left eye had a visual acuity of 6/6. The anterior segment was within normal limits. The posterior segment, the optic disc in the right eye had a vertical cup to disc ratio of 0.3. But there was a grayish white excavation in the optic nerve head. It was noted in the temporal aspect of the disc. The macula in the right eye had a macular edema with loss of the foveal contour. So this was the pre-operative fundus photograph where we can see the grayish white excavation that is seen on the temporal aspect of the optic disc, and we can see a loss of the foveal contour due to the edema. So an OCT was taken in which the central macular thickness was 971, and we can see the edematic fluid that is getting accumulated in between the retinal layers. I took a section of the optic disc where I could see an excavation at the level of the optic disc area and the fluid going into the retinal layers leading to a retinoschisis. So I did a digital fundus angiography in which I noted early hypofluorescence and a late hyperfluorescence at the excavation area. So my provisional diagnosis is a right eye optic pit maculopathy. So we decided to manage this case with Orcott assisted PPV, Brilliant Blue assisted ILM peeling, fluid air exchange, and C3F8, followed by prone positioning of the patient. So here basically I have a video that will give you a view. So initially we had done a 3-port pars plana vitrectomy. The surgery is actually very much similar to the macular hole surgery that was done by Dr. Devashish sir. So my job is more than half done. So here I can see a grayish white excavation on the temporal aspect of the optic disc. The core vitrectomy is being done. And now triamcinolone has been given basically to stain the vitreous. The brilliant blue dye has been given basically to stain the ILM. And now we are going over the ILM peeling. The ILM peeling is similar to that of the anterior capsulorhexis that we do in case of a cataract surgery, but since this is done in the macula, we can also call it as a maculorhexis. Now we have given the PFCL so that we can have better maneuvering of the ILM that has been taken out. And finally, the ILM that has been peeled is put into the optic disc pit. And the surgery was ended by a fluid gas exchange followed by C3F8. Now, the post-operative best corrected visual acuity after 1 month was 6/24, which was 6/60 earlier. So here I have the OCT, which was earlier nearly 980 central macular thickness. It has come down to 480, and it's showing improvement even after 2 months. So this is the pre-operative fundus photograph where there was like the excavated area and with the loss of foveal contour. And here we have the post-operative photo with the excavated area that is almost closed and there's a decrease in the edema. Thank you.
Thank you, Shepshan. It was a nice case.
Thank you, sir.
Only a couple of comments. So people do laser very faint burns along the optic disc pit temporally, because that also prevents further fluid leakage.
Yes, sir.
Second thing is, for someone who has not picked the optic disc pit or the optic disc pit is kind of occult, where you're not exactly seeing. This is a very obvious optic pit.
Yes, sir.
But sometimes the pit is not very clearly seen. So you do a good OCT, sometimes a swept source OCT, which goes much deeper, and then you can actually see the communication, like you've already shown.
Yes,
sir. And lastly, pit. Somebody may actually interpret this as a CME, and not actually think about the optic disc pit. So when you see fluid which is like a schisis-like cavity, this is pit, typically looks like a foveal schisis. And that is where you should very much suspect that it's probably optic disc pit related and not really like a CME. So that, the morphology of the OCT in a pit related maculopathy is quite characteristic, though it is not sine qua non, but it's very characteristic. So don't mistaken it for a CME and, give anti-VEGFs and all of that. And, filling the pit, a lot of people have even used sclera, autologous sclera. You take a small bit of the sclera and then you place it in. So, lastly, some people say that ILM peeling is not essential, and some very experienced surgeons, I don't know whether some of you have heard about Dr. Dhananjay Shukla. He is one of the most experienced, and he has done a lot of work on macular holes, and he says that he has created more macular holes than closed. Because when you start pinching in the beginning, you will realize that, if you do an OCT from the area that you have pinched, many times you will see a full thickness defect there. So it's not a macular hole, but it's a retinal hole that you have created. So that is possible. So ILM peeling may or may not be always necessary. And lastly, that these patients are relatively young, so inducing a PVD is not very easy. Like here also, there was a little bit of a tug and a pull.
Yes, sir.
So some comments on that. Anybody has any questions, if at all? Yeah, so I think you're talking about natural history. So generally, most of these people remain at 660, and no, but then they'll generally end up with 660 or worse. And if we don't treat them,
yes,
fluid takes a long time to go. So here already you're seeing good results. But generally this
within
entire
1
thing
month.
to flatten will take at least 6 months.
6
So
months.
don't think of doing anything and say that we have failed, because this is already, this is
Improving.
generally how we see it. Yeah, so some people say CSF, but most, I think, recent studies say it's the vitreous. It's the vitreous.
That had a good effect.
Yes, sir. So yeah, that is also a good approach. Okay, thank you, Shaivan.
Thank you.
I'll call the next speaker, Dr. Sangeeta, present a case of CSR.
Hello. Yeah. Yeah, as Shubhashji was saying, while doing the ILM peeling in such cases, sometimes you tend to create an iatrogenic macular hole. Beyond the pinch retinal break that you mentioned, but you can also create a macular hole full thickness while peeling the ILM over the fovea. So it's better to do a fovea sparing ILM peeling if you are considering one. And secondly, in regards to what Dr. Biswas was saying, I mean, very early on, if the like let's say a teenager, I mean, presents to you with a optic disc pit with a neurosensory detachment, there you can go non-surgical in a sense that we can try out the gas tamponade and around 14 days post the tamponade you can do a gentle laser and see. I have patients, I mean this technique of plugging the optic disc pit with ILM and various other things is a newer thing. You know, when we who have been practicing retina for 20 plus years, initially we were not exposed to this. So we have patients where vision have improved by a relatively more conservative procedure like a gas tamponade followed by a laser barrage kind of between the.
Yes, yes. Around the disc margin, a little bit of a laser, because on the temporal side, if you do more laser, then the papulomacular bundle will be damaged. So
And
that's
as
why on the nasal side I used to do and give mild laser on the power on the.
So we'll go to the next case if because we can get back to the discussions later. Please go ahead, Sangeeta.
Good morning, everyone. I am Dr. Sangeeta. I am here to present my case. This 28-year-old male patient came here with the complaints of blurring of vision and floaters for 3 months, and there was no history of any systemic illness or any allergy. On examination, visual acuity, right eye 3/60, left eye 6/9, and IOP and slit lamp examination, there was no abnormality we find. And this patient diagnosed as a case of leakage elsewhere, and this DFA and OCT were taken, and they started IVMB 1 gram daily for 3 days and oral steroid for 17 days, and due to progressive worsening of vision, they stopped all the medications. And this was the first fundus photo we taken, and here we can see macula dull, and in between macula and disc there is whitish subretinal material we find. And this was the fluorescent angiography. Here in serial photos, here in right eye we can see ink blood leakages and late phase leakage, and left eye we can see ink blood leakage and smokestack leakage. And this was his OCT angio at choriocapillaris. We can see shadowing effect, and there is no abnormal vascular network was there. And our diagnosis was bilateral central serous chorioretinopathy worsened after steroid therapy. And we reassure the patient and start tab eplerenone once daily for 3 months. And this was the first follow-up fundus photography, and here we can see subretinal deposit were resolving, and in OCT there is subretinal hyperreflective lesion resolving and subretinal fluid resolving. And this was the 2-month fundus photography. Here almost subretinal material resolved, and there is formation of fibrosis, and in OCT complete resolving of subretinal fluid, and still subretinal hyperreflective lesion persistent. And this was the last follow-up. Here in fundus photography there is fibrosis still persisting, and subretinal hyperreflective lesion completely resolved, and patient acquired his visual acuity, right eye 6/12 and left eye 6/6. And conclusion, diagnosis of acute leakage and CSCR may pose diagnostic challenge, Accurate diagnosis can be established in most cases on the basis of clinical examination and ancillary imaging. On fluorescent angiography, we get multiple pinpoint leakage and late patchy hyperfluorescence, whereas CSCR, we get ink blot and smokestack leakages. And on OCT, in VKH, serous detachment is multiloculated, whereas in CSCR, serous detachment is not multiloculated. Thank you.
Yeah, that's a great case. So VKH and CSCR are quite difficult to diagnose when they come to at this stage where it is, very, very fulminant. And so a couple of things that she's already said. If you can go back to one of your OCTs, I just wanted to show any OCT, the previous OCT. So if you look at the choroidal thickness, you will see that it's a massively thickened choroid. Okay, this is called this is a typical example of a pachychoroid. So if you go back one or two more OCTs, you will see the right eye, the choroid is, if you see that choroid, you can't really see the lower end of the choroid. So this is as soon as you see pachychoroid, think about CSR, because CSR is very much commoner in pachychoroid. Other way to, of course, differentiate is FFA. You have to do an FFA. So these are few indications where FFA is a must, because nowadays we don't really do FFAs. So a lot of multiple pinpoint leakages. It's typically called a starry sky, and we don't see a starry sky in CSR. So, and also in VKH there are multiloculated, and also CSR doesn't leak into the inner retina much, but VKH fluid starts leaking into the inner retina, and we get something which is now called it's called Ballard or bacillary layer detachment. Okay, that is fluid above slightly at the level of the external limiting membrane. So that's called the bacillary layer detachment. So if you see bacillary layer detachment, if you see multiloculated subretinal fluids and a starry sky, that is VKH. If you don't see fluid in the inner retina, but it's mainly subretinal fluid, and also if you see pachychoroid like this and those huge ink blots, then that is CSR. So it's very nicely managed actually. If you had images of an FFA which was done in the past, before they started treatment, then that would have been good, but they probably didn't do it, or they probably didn't think about it. It's very important to differentiate these two, because it's, the treatments are so diametrically opposite.
Before starting steroids, Shubhajachi, I think we should mention this point. Before starting steroids, one should carefully examine the vitreous. In VKH, there would at least be some vitreous cells. So if you are not picking up any vitreous inflammation, if necessary, even do an ultrasound if you are not quite sure on the slit lamp to see whether the vitreous is quiet or not. And beyond all that you said, extraocular. And another extraocular features like vitiligo, tinnitus and all, which can be there. And in VKH, the SRF would be turbid classically, and in CSR typically it is clear.
Okay. So one point to highlight in this case, the patient actually worsened after the exposure to steroid. Vision dropped down to 3/60. Even if it is CSR, the vision is dropped down to 3/60 level, because we know that CSR is exposed to steroid. Two things happens: leak becomes multifocal, and second thing, the SRF becomes fibrinous, more of fibrinous SRF. So that's what there is a loss of vision, drop of vision, and there is fibrosis. And most of the CSR doesn't end up with the subretinal fibrosis. In steroid, exposed to steroid leads to this kind of picture. So multifocal CSR as well as the fibrinous SRF.
Thank you, sir. So we'll go to the next case. Please get started. Go ahead.
Good morning, everyone. Myself, Dr. Sangjukta Chaudhuri. Today I am here to present my case. 14-year-old male came with chief complaints of sudden painless loss of vision in left eye for last 6 weeks. There was no significant medical or surgical past history. On examination, visual acuity left eye was finger counting at 4 feet. In fundus examination, left eye showed multiple whitish lesions around the macula. Our provisional diagnosis was left eye choroiditis. Then blood investigations showed CBC normal, renal function test was normal, chest X-ray was normal, Mantoux test was negative, but quantiferon TB Gold came positive. Then in a fundus photo, we can see multiple whitish lesions around the macula. In OCT imaging, there are hyperreflective lesions in central fovea. And in OCT angiography, in choriocapillary level, we can see some hypo spots which corresponds with our fundus picture. We then referred the patient to a physician for systemic evaluation. Patient was started on antitubercular drugs by the physician. Systemic steroid, PPI, and TEP Shalcal was also started by us. In 1 month follow-up, visual acuity improved to 6/36. Fundus showed resolving choroiditis. And in 10 months follow-up, patient was stable, medication stopped. Visual acuity was 6/24. Fundus showed healed choroiditis. Then again, after 2 years, patient came with complaints of diminution of vision in left eye. He was also seeing distorted images. Then the visual acuity was 6/36. Fundus image showed macular scar and hemorrhagic spots around. In the OCT image, we can see shallow irregular elevation of RP. And in OCT angiography, in the outer retina slab, there is a neovascular component formation. So then we did a DFA in which we can see initial lacy patterns, which later on increased in size and intensity, showing the leakages in later phase that confirmed our diagnosis to be CNVM left eye. Patient then received multiple intravitreal injection, bevacizumab. We gave him 3 such doses at 1 month interval. After completion of 3 months doses, patient came to us for follow-up. Then on examination, fundus showed CNVM scarring. Then OCT image, OCT showed hyperreflective lesions. And we can see in outer retina slab, in this follow-up, there is complete resolution of the neovascular complex. Then the patient maintained that visual acuity, and after 5 years follow-up, visual acuity was 6/36. Fundus left eye showed resolved CNVM. We can see in the fundus image, there is a macular stir, and in OCT angiography in the outer retina slab, we can see that resolved CNVM. To conclude, choroiditis, even if treated, may lead to CNVM. DFA and OCT angiography play an important role in detection and follow-up of such patients. The prognosis for inflammatory CNVM varies depending on the extent of the disease, extent of the inflammation, associated systemic diseases, response to treatment, and the presence of any macular scarring. Early diagnosis, prompt initiation of treatment, and multidisciplinary collaboration with continuous monitoring and tailored therapeutic intervention are key components in managing this challenging condition. Thank you.
A very good morning to all of you. On a busy routine OPD day, a 42-year-old female came with us with a complaint of sudden diminution of vision of right eye since 2 days. She did not give any significant systemic history. On examination, the visual acuity was right eye, finger counting 1 feet, and RAPD was positive in right eye. All the anterior segment findings were within normal limits in both eyes. On fundus examination, we can see there are dilated, tortuous arteries and veins, which are more prominent in the infratemporal quadrant. We can also see in macular region there are pre-retinal and subretinal hemorrhage. On OCT, we can see a localized posterior hyaloid detachment with multi-layer hemorrhages seen. On fundus fluorescent angiography, we can see the vessels has been filled up with the dye with no leakage seen, and there are blocked fluorescence which are suggestive of pre-retinal and subretinal hemorrhage. So provisional diagnosis made was a retinal racemose hemangioma. But where did these hemorrhages come from? We didn't know at this point. So systemic investigation were advised, MRI brain and USG abdomen, to rule out any other AV malformation. Treatment given was intravitreal C3F8 gas after doing the paracentesis, and patient was asked for strict prone position. On post-op, visual acuity has been improved to 6/60. We can see a gas in superior quadrant, and submacular hemorrhage has been seen dispersed inferiorly. OCT also shows a reduction in submacular hemorrhages. But after 2 weeks, the vision has been improved to 6/36. Hemorrhages has been dispersed inferiorly, And on close examination at the macular region, we found vessels which is dilated. It was a case of retinal artery macroaneurysm. So on OCT, we find localized posterior hyaloid detachment with small NSD. To ablate the focal RAM, we advised a focal laser in a small energy with long duration. But to our surprise, VMT has been increased, visual acuity has been further dropped, and there was no hemorrhages seen in posterior segment. So we can either go for a surgery or a YAG hyaloidotomy. Surgery was not advised since it can lead to increased bleeding, and laser was done. In post-op, we can see the hemorrhages has been resolved. The localized posterior hyaloid detachment has been released with residual foveal thinning. Concluding my presentation, retinal racemose hemangioma is a rare unilateral, non-hereditary and sporadic phacoematosis characterized by a AV malformation. Archer et al. Has described this AV communication into 3 groups. Thank you everyone for hearing me out. This is Dr. Sajal Golcha, a resident of Shushruth Eye Foundation. I would like to thank all my mentors for the guidance and support.
Thank you for the nice and relatively uncommon case. So you said there is a retinal artery macroaneurysm as well, right?
Yes,
so
sir.
I don't see too much of evidence of a macroaneurysm exactly. And it's so that's what. So you need to substantiate it with an angiography. If there is too much hemorrhage, then an ICG will suffice. ICG will generally show, when nothing else shows, ICG will throw up something. So macroaneurysm has to be, so I'm not really sure whether there was a macroaneurysm. So where did this bleeding come from is something which we are not sure. Many times these huge racemos, I have also seen one case like this, many times that there is an evolving PVD, which you have seen. That PVD, so that PVD can tuck on some of these vessels and you can have rupture and bleeding that way also. Minimal trauma can also lead to some kind of hemorrhage. She's a 42-year-old, maybe there was some kind of violence around her, or just a trivial trauma which people don't remember can also cause this kind. So I'm not really sure there was a macroaneurysm, but it was of course managed nicely, and so this was likely to be an evolving PVD causing. If people who don't have huge vessels like this, you will see very small petechial hemorrhages, and sometimes they look like a diabetic retinopathy, but they will go away. Even during surgery, when we are inducing a PVD, sometimes you will see few bleeders here and there. So because it's a very large racemose hemangioma, perhaps she has had more bleeding, but then I don't think there was a RAM in that. Okay, thank you so much. No, most likely it would be less because it has been displaced nicely with a pneumatic displacement and vision has improved. So if the hemorrhage was there for much longer, vision would really not have improved. So it was probably a fresh case. Okay, we'll go to the next case. Thank you so much.
Good afternoon, everyone. Myself, Anjali Suryavanshi. I am going to present a case. So 18-year-old female came with chief complaint of gradual diminution of vision in left eye since 1.5 months. And so she visited to nearby hospital and they have suggested USG-B scan. And they referred the patient for surgery, pars plana vitrectomy plus membrane peeling and fluid air exchange. Then there was no history of any systemic illness and no history of contact with any animals. So on USG-B scan, we can see numerous low to medium reflective echoes in vitreous along with the high reflectivity membrane like structure as arising from optic nerve head and extending nasally. On ocular examination, visual acuity on right eye was 6/6 and on left eye finger counting at 1 feet, and IOP was within normal range, and slit lamp examination was within normal range. On fundoscopy, we can see right eye optic disc and macula seemed normal, and left eye dense vitritis was seen, and a membrane formation was there, and retinal details were not couldn't be appreciated. Then investigations were done which were within normal limit. Then considering the fundus photo which shows vitritis, Toxocara granuloma was suspected and patient was started on tablet albendazole 400 mg BD for 4 weeks, tablet prednisolone in tapering dose and tablet pantoprazole 40 mg OD and tablet calcium 500 mg OD. So this is a picture after 2 months, 2 months of follow-up. Fundoscopy was done, which show resolving granuloma and visual acuity improved to 3/60. So after 4 months of follow-up, visual acuity was 3/60 and there was a fibrovascular membrane with tractional retinal detachment involving macula, and on OCT there was a irregular RPE layer and a thickening of neuroretinal limb and subretinal fluid. So after 1 month, surgery was planned, 27 gauge transscleral vitrectomy with membrane peeling and fluid air exchange. So after surgery, after 1 month of follow-up, visual acuity improved to 5/60 in left eye, and there was subretinal fluid subsided, and macular details were normal as compared earlier, and there is a falciform layer. There was a falciform layer nasally, and there was no traction seen. So this is the picture before treatment and after treatment, in which visual acuity, when patient presented, visual acuity was finger counting at 1 feet, and this is after treatment, in which visual acuity was 5/60. Thank you.
Yeah, thank you. Nice case. Again, a little bit of a diagnostic dilemma. So during the surgery, what was done was only tackling the macula, right? The
So
nasal membrane and the granuloma were left alone.
So membrane peeling was done.
No, but there was a thick band which is
So
starting
it
from the
was
disc going nasally.
away from the optic disc, so it was left behind. It was very difficult to operate, so it was not done.
That's what. So, sometimes these are very vascular also.
Yes, sir.
Though they look very white, if you try and bisect it, or we do segmentation or lamination, sometimes this can really bleed significantly. So luckily this was on the nasal side, and it could be left alone. Many times we leave diabetic membranes also, very large, thick membranes, which we feel will bleed. On the nasal aspect, sometimes can be left alone, and they generally don't worsen. So what you were initially presented was like a membranous kind of vitritis. A lot of vitritis with membrane formation. It is not very common. Only couple of entities, or 2-3 entities. One is of course Toxocara. Generally, the granuloma is much more peripheral than what you have seen. Other entity, uveitic entity, which is known to cause this is Leptospira. So Dr. Rathinam has done a very large series, and she has shown a lot of membranes. So in that part of the country, if they see vitritis with a lot of membranes and not too much of inflammation, they think about leptospirosis. That's another, perhaps a differential here. But yet, Toxocara is not really something that is confirmed. This is still presumptive. Though we have treated and it's gotten better, but if you give steroids for most of the uveitic entities, they are going to subside. So anyway, it's well managed. So I think that's about it. Thank you so much. So we'll go to the next case. Shubham.
Good afternoon to all of you. Myself, Dr. Shubham, DO first year PGT, second site, South End Eye Center. I am here to present a case on a patient, 64-year-old male patient presented with chief complaint of diminution of vision in both eyes from last 2 to 3 weeks. Diminution of vision was painless, acute in onset, non-progressive in nature, and patient had difficulty in seeing objects on right side. No history of trauma or any such episode in past. No history of any systemic illness. On examination, visual acuity in right eye 4/60 improving to 624 and left eye 636 improving to 624. No RAPD and IOP was within normal limits. On slit lamp examination, right eye NS2 and cortical, left eye NS1 cortical was there, and CD ratio in both eyes was 0.65, and in left eye mild temporal pallor was there, and in macula mild RPE changes in right eye were present. Color vision was normal in both eyes. On confrontation test, defect was seen in nasal hemifield of right eye and temporal hemifield nasal hemifield of left eye and temporal hemifield in right eye. So HVFA was advised. Then HVFA 24-2 was done. Bilateral right-sided congruent visual field defect respecting the vertical meridian can be seen. And then HVFA 10-2 was done, in which macular sparing was seen. So this kind of picture mainly comes when the lesion is present retrochiasmal in the visual pathway. So the differential diagnosis is can be due to vascular, neurologic, or infectious or iatrogenic cause. Blood investigation, blood sugar and lipid profile were within normal limits except the elevated homocysteine level, which was 32 micromole per liter, and blood pressure was 150/70. So on the basis of this, the provisional diagnosis was made right-sided homonymous hemianopia, which may be due to any retrochiasmal lesion, may be associated with raised homocysteine level. Then MRI brain was advised and patient was then referred to neurologist and hematologist for further evaluation and management. Then MRI brain findings, acute infarct was seen here in the left occipital lobe. Then MR angiogram of cranial and neck blood vessels was done and was within normal limits. Neurologist advised physiotherapy, tab ecosprin, atorvas, and visual rehabilitation. Visual rehabilitation can help these patients to lead a normal life. For that, prism can be used to displace the image towards its apex from the affected side to the normal side, and visual training can be given to detect targets in defective hemifield. Conclusion: any disturbance in vision which cannot be explained by doing refraction and examination of fundus, especially one-sided disturbance of either eye, should be investigated by asking for perimetry or visual field test, and homocysteine level should also be included in blood investigation if no other vascular or systemic risk factor is present. Thank you.
Thank you, Shubham. Again, a relatively straightforward case. However, I would not always label it as homocysteine induced because patient was diabetic, hypertensive, 64-year-old. So, there are a lot of risk factors for vasculogenic strokes in this case. So, anything could have caused it.
Sir, no systemic that...
I thought you have written... But anyway, patient is 64-year-old person, right?
Yes, sir.
Yeah, you might have investigated and seen other things, but yeah, so not always homocysteine will be causative in that age group. Other thing is, many patients say, I am not seeing by my right eye. People very rarely will somebody say, I am not seeing on the right side. Most people will say, right eye, I am not seeing. But then you have to be astute enough to find that it's a hemianopsia, where both eyes are involved. So at least for people who are training, you will say, patient will say, oh, my right eye I am not seeing. But then, when you examine, you are almost never thinking about the left eye. So this hemianopia diagnosis is not very easy to make, just when you're sitting. So remember that, if you're suspecting and everything looks normal, both eyes are absolutely symmetrical, there is no cataract, the fundus looks absolutely normal, and you can't explain that one-sided vision loss, think about that it could be hemianopia. Also, the more posterior the infarct, the more dense the scotoma, generally, because everything is getting crowded in that occipital lobe. So you saw how dense that scotoma is.
Yes, sir.
So the denser the scotoma, the more posterior the lesion. And generally, so this was a small infarct, therefore you have, some people get occipital large infarcts and cerebral blindness, where both eyes like finger counting. That is another extreme. But this is, so patient has gotten away relatively, it's not that it's good to have this, but, so that's a small infarct and, vision is still 624 and can still be trained and rehabilitated.
Yes, sir.
So overall, relatively straightforward case, but some points to learn. Okay.
Excuse me,
Thank you,
one more point I want to make is that if in a clinical scenario when there is a fresh stroke and one has to see a patient who says that people say, the relatives say that the patient is not being able to see in the left side. So in such cases, the spatial neglect has to be considered in clinical scenario. So here in the parietal, especially posterior parietal cortex lesion, the patient's spatial awareness goes. So even if the visual field is intact, patient will not be able to move the eye or be aware of the space in the left hand side of the thing. So in such cases, some specific tests are done. You ask the patient to bisect a horizontal line with say something, or ask to make a clock face. In such cases, the spatial neglect can be clinically separated from hemianopia. And this is important clinically, and its spatial neglect is mainly in the left side, and it is mainly seen in the posterior parietal cortex lesion.
Super, great point. Thank you, sir. We will go over to the next case.
A very good afternoon to all present. I am Devaduti Chatterjee, final year PGT from Regional Institute of Ophthalmology, Kolkata. I shall be presenting a case of secondary glaucoma induced by silicone oil. A brief overview about the patient. He was a 45-year-old patient who had no history of any chronic illness. He had a history of cataract and rhegmatogenous retinal detachment surgery with silicone oil installation, and inferior PI was done in the right eye in June of 2021. There was a history of silicone oil removal of the right eye in November 21. The patient was on maximum anti-glaucoma medications and was referred to our center for further management. There was no history of any other pathology in the fellow eye. So the patient followed up with a dull aching pain and redness in the right eye after silicone oil removal. Intraocular pressure was found to be raised in the right eye, which was around 36 millimeters of mercury in December. A repeat silicone oil removal was attempted, but still the IOP was found to be raised. The patient was put on maximum anti-glaucoma medication and was referred to us at RIO. So the ocular examination revealed a best corrected visual acuity of FC 2 feet in the right eye, and the left eye was 6 by 6. A conjunctiva had mild congestion in the right eye. Cornea was clear in both eyes. In the iris, inferior PI was seen, which was patent in the right eye. The pupil was irregular and reacting to light in the right eye. In the left eye, it was normal. Lens was pseudophakic in the right eye. Anterior chamber was deep with silicone oil bubbles present. The left eye was deep and quiet. Intraocular pressure was 32 millimeters of mercury at presentation at RIO and 18 millimeters in the left eye. Gonioscopy showed wide open angles in the right eye with silicone oil bubbles in the angles and wide open angle in the left eye. Dilated fundoscopy showed a VCDR of 0.4, healthy neuroretinal rim, macular scarring was present, and tessellated fundus in the right eye. And the left eye, it was within normal limit. Anterior segment photography showed silicone oil bubbles in the anterior segment, and a gonioscopy was done which showed silicone oil present in the angles. A fundus photo of both the eyes are seen with macular scarring which can be seen in the right eye, and left fundus was within normal limit. Now the big question is whether we should go for a glaucoma drainage device or a filtration surgery. The preferred method in case of secondary glaucoma is a drainage device, reasons being is long-term effectivity of the device, use of minimal anti-glaucoma drugs post-operatively, comparable complications compared to trabeculectomy, and reduction of IOP effectively to the desired levels. A number of studies have shown a similar thing, that glaucoma drainage devices show a better control of IOP rather over trabeculectomy. So I'll be showing a video presentation by Dr. Tania Rai Bhadro, who is the assistant professor at RIO. Conjunctival peritomy is done. Mild cautery is done. Wet field cautery is being done here, as can be seen. The Ahmed glaucoma valve is placed in the superior fornix. It is held in place with 10-0 monofilament sutures. Pilocarpine is instilled in the AC. The valve is cut to its desired length. A small tunnel is made, and the AC entry is done with a needle, and the valve is inserted into the AC, as can be seen. The tube is fixed to the sclera. An amniotic membrane is placed over the bare sclera.
Are you done with your presentation, or are you still having slides?
There's a few more.
One question. Shall I go for a question?
Yes, sir.
Yeah, I think your presentation is, I think we don't have much time. Please go ahead, sir. Yeah.
Just one question. Why to use amniotic membrane?
So if we place it over the graft, it will help in proper healing because the sclera is exposed as that region.
No, amniotic membrane will get absorbed within few days. So you need to have some solid like scleral or pericardial patch for that. It has been described either with scleral patch or a pericardial patch, because it is not the question of healing or as such in that place. That place is totally not required. Healing is not required. Healing is required where beyond the valve, at the posterior level,
okay,
where the fluids are coming out. So in this place only, this is basically for fixation. So you need to have a mechanical, good thickness, mechanical material for that. So I don't think amniotic membrane has got any role in such case.
So definitely amniotic membrane cannot be used. Amniotic membrane cannot be used in this. It has to be a scleral patch graft. You cannot use amniotic membrane, absolutely not.
Yes, sir.
You said amniotic membrane,
place
right?
the graft, patch graft, just for proper healing and. Yes, sir. No, over the sclera it was placed.
No. Over the sclera you have put amniotic membrane.
Yes, sir.
Yes, amniotic membrane cannot be used. One. Second thing is that entry is too close to the limbus. At least 2 millimeter. People, I do AGVs not very frequently, but this is too close. You've just made it even closer to the SICS incision. The people have described non-patch graft also, but then they make at least a 3 millimeter intrascleral tract and then they push the tube through that. This is going to get exposed. Then a much longer tunnel. So that is a patch graft free procedure, but this is not really how it is done. Also using a 10-0 nylon to secure that is not at all, it's...
10-0 nylon is very fragile.
10-0 nylon...
Especially with the edge of the valve, it gets cut through. I use, even they recommend 9-0 nylon, I use 8-0 nylon. I find it much better.
Or you can think about perhaps a 10-0 Prolene maybe, or some people even use an absorbable suture, but then the tract has to be much longer. This is just, just at the gray zone. It's just a stab incision, like a side port almost, a little posterior. This is just too small. And there is too much of it exposed subconjunctivally. This is really not how an AGV should be done. That's about the procedure. Also, I'm sort of curious why the lens was sacrificed in a patient when he had rheumatogenic retinal detachment. Typically, a 45-year-old person who is phakic will have a scleral bucklable retinal detachment, where there is a tear and there perhaps is a localized detachment and others. So, young patient who is particularly 45-year-old, it's preferable to go for a scleral buckling surgery. As soon as you start sacrificing the lens and putting on oil and other things, these are all sort of things which could happen. So avoid silicone oil. Young patient, 45-year-old, don't sacrifice the lens unless it was unless it was traumatic and it was opaque or whatever. Sometimes patients have vitreous hemorrhage. So just do a vitrectomy. But sacrificing the lens is something that everybody should be relatively wary about when you're doing a retina surgery. All right, we'll go to the next. Yeah, that's also another approach. Pars plana approach is another approach. So that also can be done,
So we did this.
Okay, we'll go to the next presentation.
Hello everyone, I'm Dr. Anamika Paul. I'm a junior resident in RIO, Kolkata. Today I'm here to present when not to operate in a case of traumatic cyclodialysis cleft. So we have got a patient who's 9-year-old male with a complaint of progressive painless swelling in the left eye since the last 6 months and a dimness of vision and redness in the left eye. So he had a history of left eye, he was hit by a stone 3 years back. He suffered a corneal limbal rupture in his left eye from 3 o'clock to 5 o'clock position. The rupture repair was done outside, and best corrected visual acuity of HMCF, hand movement close to face, PR accurate was obtained in left eye. So we went on with the examination part when he came, and BCVA of PL plus PR accurate was obtained, and pupil was sluggishly reacting in left eye, and a large transilluminant vascularized bleb measuring around 10 millimeter into 5 millimeter size, extending circumferentially along the limbus from 3 o'clock to 6 o'clock position can be seen. The cornea had edema, and bleb was encroaching on the temporal part of the cornea. Nasal part of the cornea was clear. Anterior chamber was shallow, and there was no reaction as such, but lens was cataractous. The IOP in the left eye was 6 millimeter of mercury, and central corneal thickness of 610 microns was seen. Conioscopy in the left eye could not be done because of the bleb which was encroaching on the cornea, and the globe was hypotonous. And a dilated fundoscopy was also not done because of the media opacity. So we went on with the USG P-scan. So in the USG P-scan, we could see that because of the hypotony, we had certain differential diagnosis in our mind. So we could not see any retinal detachment or any choroidal detachment or any vitreous echoes. We did an ultrasound biomicroscopy. Here we could see there's a gap. The red arrow is showing a gap between the ciliary body and the sclera. So this confirmed about the cyclodialysis cleft, and we went on with our management. We planned the patient with conservative management at first, and then we started cycloplegic atropine 1% BD in the left eye and topical steroids. We continued it for around 3 months. At the end of 3 weeks, we could see that the IOP is rising. So we had planned the patient for intervention also, but we did not do the intervention since the IOP was rising. So after the end of 3 months, we could see the bleb has started reducing, and at the end of 6 months, the bleb had completely resolved. IOP had increased to 11 millimeter of mercury, and a repeated UBM showed closure of the gap between the ciliary body and the scleral spot. But the vision still remained poor because of the media opacity. There are certain literature present in which they try to manage the case with some interventions, but we did it with medical management only. Thank you.
Thank you so much. Again, this management of these kind of clefts should be stepwise, where initially we try medical management, and majority of patients respond to that. And sometimes it doesn't depend on the size of the cleft, because even large clefts I have seen responding well to atropine and intensive topical steroids. So directly going for surgery is probably never an option in any case. Wait and watch. Sometimes it takes 2 to 3 months of atropinization for these clefts to close. But then if the media was, if you were able to see the media and there is hypotony maculopathy setting, or there is choroidal detachment which is happening, then you need to think about surgical intervention early. But then in your entire careers you may do maybe 2 or 3 cyclodialysis cleft repairs. It's not common at all. Sometimes it can also be done with a cryo, where you know
Yes,
where the
sir.
cleft is, and because of the UBM, and then you go and do, it's like a ARC, or it's an AR anti-retinal cryo-like applications, and that itself could seal the cleft. If that also doesn't work, then perhaps you can go and explore
Dilate,
and
direct
then-
cyclopexy.
and then you could think about a cycloplexy. That is not an easy procedure. It is a relatively blind procedure. Even if you know that it's at this clock hour, sometimes you may open and see, oh, I can't see the cleft at all. So then opening up is really not a good idea in these kinds, and you always hope that it resolves with medical management, like it does in most cases. So thank you so much. I think it brings us to the end of this session. We have
Session 3.
Dr. Chandana Chakraborty. She will be also presenting.
At the outset, I want to thank to SWB and the second side, south and second side team, especially Dr. Debashish Boidagi, for giving me opportunity. People may think, wow, what is new about the interesting case? Because from the morning we are listening, we are going through all interesting cases. So I don't know why Debashish has put that interesting case for this one. So maybe your expectation is high. See whether it can keep your expectation. So my first case is COVID-19 rapid antigen test, an unexpected complication. The diagnosis of coronavirus disease is based on detecting viral RNA in the nasal cavities and the nasopharynx. Millions of nasopharyngeal swab tests were performed daily worldwide since the global spread of COVID-19 pandemic. Complications of the procedure are uncommon, but occasionally they can have dangerous consequences. Coming to my case, a 72-year-old male, he came with pain, swelling in the right eye since one day. He gave an history of a painful RAT test, rapid antigen test, day before yesterday. There was no history of neurological disease like previous surgery or trauma or nose bleeding. He was apparently well before this testing. So coming to the ocular examination, there was periocular edema, mild proptosis, visual acuity was 6/12 best corrected and restricted extraocular movements, painful, especially in the medially and up gaze. There was RAPD and mild disc edema. We hospitalized the patient on the second day, thinking that it could be a case of orbital cellulitis, and IV broad spectrum antibiotic was started. If we look at this imaging, the first one is that imaging of is a boat-shaped lesions showing the NCCT that is in the roof of the orbit, extending medial wall. And in the sagittal one, you can see there is again this lesion is there. This is an hyperdense lesion. MRI was done slightly later date, 7th day I think. It also shows in the axial view of the MRI. The thing is persisting, the lesion. And when the patient was not improving after 7 days also with our maximum dose of injectable preparation, broad spectrum antibiotic, I forgot to tell one thing. From the third day, we started oral steroid as actually the RAPD was persisting and the vision was deteriorating. So we started oral steroid also. So this was the picture. We did an USG guided aspiration through the transcutaneous approach, that is superiorly where the lesion is exactly located, and almost 7 ml of blood was taken out. So looking at the description, the time frame, the clinical features and imaging points, all these point towards an orbital subperiosteal hematoma caused by an injury to the RAT test. The patient was doing well. We discharged the patient. We asked the patient to go for an ENT checkup. The patient refused to go there. After 2 months, again there was some amount of swelling and pain. Then the ENT consultation was done, and they did an endoscopic evaluation, and they found that this, you can see clearly there is an erosion. They told this is an erosion. We will go for the drill of this ENT surgeon. They did this drilling, and they took out some inflammatory material to the endoscopic approach. So this was the case. Now the patient is doing well. These are the differential diagnoses one should keep in mind. One is orbital cellulitis, one is subperiosteal abscess. So what we can do in this type of case come to us. One is observation. If it is a very small hemorrhage, it can be spontaneous resolution. Maybe they are in case of traumatic subperiosteal hematoma. But in our case, we had to aspirate. Either you can go for a needle aspiration, but needle aspiration, though it is a very simple one, but you cannot, sometimes you can miss some clotted blood, and that can give rise to some other complication, chronic inflammation that can give, which happened to this case. And this you can do surgical evacuation also, which was done later, subsequently. So to take home, proper instruction should be given about the nasal anatomy to the healthcare professional performing nasopharyngeal swab tests to avoid such potentially dangerous complications. The direction of the swab should be always along the nasal floor. Excessive force should never be applied, and prompt diagnosis and management can prevent the visual loss and other complications like in this case. So I'll quickly go to my next case. This was a case of intraorbital wooden foreign body. This is many times you have come across this type of cases, but this was a bit tricky. Why tricky? It was a case of intraorbital wooden foreign body impinging the meninges along with an orbitocutaneous fistula. So look at this patient. The patient was 44-year male, and he was with this type of discharge for last 3 years. Why? On questioning, he told that no surgeon is, the surgeons are telling everywhere I have consulted, they said that as your CT picture is suggestive that it has gone inside the cranium, so it can cause injury, impair your vision. So what was the vision likely? See, it is a 6/6 vision. There was a grade 2 RAPD. The fistula, as you have seen, there is medial ectropion, extraocular muscle restricted, conjunctiva congested, and disc edema, of course. So these are my CT pictures. As you can see, there is an hyperdense linear axial CT and CCT. Went for, and the MRI also showing this type of axial MRI. You can see it has gone, you can see this has gone in the temporal lobe. That's why actually we were also a bit hesitant, should we go for the case or not. We asked the patient to refer the patient to the neurosurgeon. They said, looking at this MRI picture, they said, no, actually it is impinging the meninges, not actually within the brain cavity, so you people can manage the case. So I did the case, and this was the simple thing, though it was not so simple when you, with an infraorbital anterior orbitotomy, it will go, the marking will go, the incision will go just through that fistula. And while there is a lot of adhesion over these 3 years, inflammation, so we have to keep on injecting fluid at the beginning through the fistula so that the thing becomes loosened and it becomes easier to take it out. So we were really in a very, in the post-op period, we were thinking whether the patient, it was a 10 centimeter wooden foreign body, you can see, we did it under local anesthesia. The patient was very cooperative actually. And thank God, the follow-up 3 months, the vision was 6/9. So we are very much happy that, but the patient doesn't want to go for a second surgery for the ectropion. He is happy with that only. So to take home, organic foreign bodies have higher rate of sight-threatening complications and infection than the non-organic, the foreign body. Organic foreign body may result in incomplete removal many times. If you do not make it a loose one with normal saline and all, you can just break it and it may remain some part. Imaging are often misdiagnosed on CT. You may have to go for a second MRI. So high index of suspicion is to be maintained in cases with history of trauma, regardless of time interval between your presentation and trauma. These are my references. Thank you. I'm ready to take any questions.
Thank you, ma'am. I think interesting cases is an understatement for what you've shown. Because I think a lot of us would not be seeing these kind of surgeries unless you showed us those. Thank you so much, ma'am. I think we have run out of time, so unfortunately we won't have time for questions.
Okay.
Thank you, ma'am. Thank you so much.
Now I'll call upon Dr. Keshav Haldar for presenting memento as a token of respect. I'll call Dr. P.N. Biswas, please. Then I call Dr. Arnab Das, please come. Then I'll call upon Dr. Champagali Vishwas and Dr. Pranab Das. Dr. Pranav Das, please. Thank you, thank you. Now I call upon Dr. Sabyasachi Sengupta as our special guest. He has come from a long distance and he has moderated it very well. Thank you, sir. Yeah. And now I call upon Dr. Rotish Chandra Pal. Oh, now I call upon Dr. Chandana Chakravarti. Thank you. There is an announcement. All those PG students who have participated, at the end of our program, they will be issued a certificate and memento. Please collect it after the program is over. Thank you. Now I welcome for all of you for the next session, that is based on glaucoma. I just request Dr. Parag Mukhopadhyay, please take the chairperson's place. So let us start our next session. As far as perimetry is concerned, in our older days we used to have Goldman's perimetry, and then static perimetry came later on, which just made the glaucoma specialist life very simple, though it is not without drawbacks. This is the topic. Dr. Niloy Majumdar is going us to enlighten us on the pitfalls in the interpretation of the perimetry. Niloy, please.
Very good afternoon. Thanks WISWB and Second Sight Eye Hospital for inviting me here. I'll be talking about pitfalls in interpretation in perimetry. It is a very vast subject, perimetry as such. I will restrict my talk to glaucoma and Humphrey visual field testing mainly. So we all know that in a usual printout, we first have to look whether the test is reliable or not. If the reliable parameters are okay, we can jump to this pattern deviation plot and the GHT, and that will give us 80% of the information so far as glaucoma is concerned. Let's come to some of the reliability factors. First is the false positive error. Here this patient probably is a trigger happy patient, has responded excessively. Look at the high, abnormally high values, and there is increased fixation loss and false positive errors too. Glaucoma hemifield test showing abnormally high sensitivity, and remarkably there is increased defect in this pattern deviation plot because computer has taken this area as normal. After proper instruction, this is the actual field of this patient. False negative error. The first picture shows a patient who initially responded, but later on failed to respond or didn't respond due to inattentiveness or fatigue. So there is almost a cloverleaf pattern here. But look at the second picture. Here, though the patient is responding normally, there is high false negative error. We have to remember that when the patient has some defect in the retina, and that is not an absolute defect, the vision and sensitivity may fluctuate. So though the test is reliable, this case may have high false negative error, and so nowadays this double cross doesn't come with the false negative error. Pattern deviation is the single most important or useful analysis, but you have to remember that if the defect is extensive like this is not useful, so this type of message comes. Glaucoma hemifield test is also very helpful so far as glaucoma is concerned, but even if it is normal, sometimes some early defects may be missed. This patient has persistent defects at the same place and a corresponding notch in the upper part, so this is a real glaucomatous defect. Visual field index is a very important index nowadays because it focuses on the central part mainly. So far as Anderson criteria is concerned, we all know, but this fulfills the Anderson's criteria because it is a non-age defect, but this is an age defect. But it corresponds with the clinical finding of this bipolar notch. So though it is an age defect, it is a glaucomatous defect. So far as progression is concerned, if we don't have these softwares, if we use this overview only, you have to remember that at least minimum 4 fields are required for evidence of progression and 6 for certainty. So only by seeing 1 or 2 fields for progression, we shouldn't should definitely say that the field is progressing. Misinterpretation may be due to different factors like artifacts or pseudoglaucomatous defects. Artifacts may be due to different causes like age artifacts due to eyebrow or malpositioned head, or the thick lens rim, or if the lens is placed away from the eyebrow too much. It may give rise to this type of ring scotoma, but it is different from a typical glaucomatous ring scotoma. See that typical glaucomatous defect starts from the blind spot as a thin defect and gets broader as it goes nasally, and there is a distinct step between these 2 arcuate defects. This patient was being treated for glaucoma suspect, probably outside, and was with prostaglandins, and came to me with this is the previous perimetry, and now the patient has developed an upper peripheral defect, an arcuate maybe, but actually the patient has a ptosis. So we did the test with lead elevation, and the defect is gone. Same thing can happen with dermatocallosis. This is a typical COVID time defect with the mask. Media opacities may also sometimes mislead us. Nothing in the pattern deviation plot. This may mimic an upper arcuate defect, but nothing in the pattern deviation plot. So we should look at the pattern deviation plot first. Errors in the perimetry procedure. There may be a learning effect. This patient had a patchy upper arcuate defect, but that didn't quite correlate with the clinical findings. So we did a repeat test after some time, and the defect is gone. Dot artifacts can sometimes happen if the patient doesn't respond to the initial spots, because these initial spots come at equidistant spaces around the vertical and horizontal meridian. This should be very, very unusual, this equidistant cases. This is slight, like opposite to this cloverleaf pattern, because in cloverleaf pattern, the patient responds to the initial these spots, but later on doesn't respond. Normal right field, but what is this? This is actually the visual field of the right eye, but the eye is placed wrongly in the left eye slot. So this is actually the blind spot, and see that the fixation loss is 11/11. So when the patient is instructed and placed rightly, this is the field of the normal field of the left eye. Pseudoglaucomatous field defects. The normal glaucomatous field defects typically has a notch and a corresponding defect, arcuate defect. There are different causes of arcuate defects. Can be due to a refractive scotoma in tilted disc. Tilted disc has inferior nasal deficient or more myopic retina. So it causes an upper temporal defect. If it is a bilateral tilted disc, can cause a bilateral bitemporal upper defect, but it may mimic a bitemporal hemianopia, but it does never cross the vertical line. The ring scotoma of RP, but I have mentioned earlier that it is different from biarcuate scotoma of glaucoma. Typical altitude defect of ischemic optic neuropathy. This patient had upper arcuate patchy defect, but look at the retina, the patient has a lower BRV also. BRA also may give rise to this type of but a more distinct arcuate defect. This patient had a optic disc drusen in both the eyes. This may also give rise to arcuate scotomas sometimes. This is a small ring scotoma, but it is actually due to this 10-2 testing. It is actually due to a bullseye maculopathy. This patient came with glioma. This can give rise to Bézier defects, which sometimes may mimic glaucomatous defect. This patient was being treated for glaucoma elsewhere, came to me, and seeing the right eye, I had a suspicion. I advised an MRI, and we found a lesion in the occipital lobe, maybe a glioma, and by then the patient gave this typical hemianopic defect. So in the conclusion, a good perimetry is essential for diagnosis, progression and assessment and management of glaucoma, and proper conduction of the test and correct interpretation of the result and clinical correlations are a must for this purpose. Many non-glaucomatous eye conditions may produce field defects mimicking glaucoma. Thank you. So clinical correlation is a must before diagnosis.
I would like
Thank
to.
you.
I would like to ask one question to Dr. Nilada. In case of doing perimetry, what are the advice or how do you educate your technicians so that you can get a better yield?
Actually, the main thing is to train the technician first.
Yes.
The first thing I do, at least I advise to do, is you do the perimetry yourself. You sit on the.
Yes. That is very important.
You sit on the seat, do the perimetry yourself, and then you know yourself what are the disadvantages and the difficulties while doing the perimetry.
Right, and then never to, isolately you interpret the single print without seeing the patient.
Definitely, that I mentioned.
Even if not only the eye of the patient, even if his gait, whether he is attentive, whether he's got ptosis, everything.
Yeah.
That has to be looked into matter.
Yeah. You
Before
see the whole
commenting.
patient, not only the perimetry report.
Yes. Now I request
Thank
Dr. Surajit Sen will be talking on bleb-related infection, a quite common condition, especially glaucoma specialists as glaucoma specialists face.
Good afternoon, everyone. First of all, I would like to thank Dr. Debashish Boidagi sir for this kind invitation. I have back-to-back 2 talks, please bear with me. First of all, I will discuss this bleb-related infection. I will start with an interesting case which I had managed there when I was there in Shankar Nethralaya. 3 departments, VR department, cornea department and glaucoma department had to work together to save vision of this 37 years old gentleman. He presented to us with a complaint of pain, redness, watering and blurring of vision in his left eye for last 3 days. There was no significant systemic history. His right eye was lost because of neovascular glaucoma. It was a blind eye, and he underwent a diode CPC for painful blind eye in 2008. It was a thusical eye, and patient was using a prosthetic shell in that eye. The left eye was diagnosed as juvenile open-angle glaucoma. He underwent trabeculectomy with mitomycin C first time in 2004, and retrabeculectomy was done in 2008. He was currently using bematoprost eye drop in his left eye once at night. This is the clinical findings. The right eye, it was no PL, it is a phthisis bulbi. The prosthetic eye shell was there. Once we removed that, there was significant mucopurulent discharge in that socket. The left eye vision was 6/6 N6 and the pupil was sluggishly reacting. Finger tension was normal. Lids were edematous. Conjunctiva was grossly congested. Chemosis, buccal discharge was there in the inferior fornix. There were 2 blebs. The supranasal bleb was flat. The supratemporal thin cystic bleb was there, but sedal test was negative. Cornea was clear. The anterior chamber was deep and quiet. There were 2 surgical PIs. Posterior subcapsular cataracts were there, and adverse cupping with normal macula was noted in undilated fundus examination. So the diagnosis was made that acute conjunctivitis of both eyes, probably bacterial, and the right eye socket was cleaned with betadine eye drop and prosthetic shell was discontinued. He was advised to use both eyes moxifloxacin, tobramycin and carboxymethylcellulose eye drops frequently, catifloxacin eye ointment at bedtime, and AGM to continue. He was asked to come for a review after next day, but unfortunately the patient reported after 11 days when his best corrected vision came down to hand movement close to face with PR accurate. This is the clinical picture of that day. The conjunctiva was grossly congested. There was 4+ AC cells. There were hypopian and hazy view of the fundus. And there was a thin cystic bleb with milky white exudate inside the bleb. Sedal test was still negative. The finger tension was not raised. So now the diagnosis is bleb-related endophthalmitis of the left eye. He was admitted in the hospital. The aqueous tap was done and sample was sent for the smear and culture. Intravitreal vancomycin, ceftazidime, and dexamethasone was given. All topical antibiotics which was prescribed earlier were continued, and prednisolone eye drop 1 hourly and atropine 3 times a day were added. And also the oral ciprofloxacin 500 milligram were added, and he was reviewed next day. The next day the situation didn't improve, so vitrectomy was done with intravitreal antibiotic injections. The vitreous sample was sent for microbiological evaluation, but the microbiology report didn't show any growth in the culture for 2 days, and the PCR was positive for eubacterial genome. On first postoperative day, the vision was still hand movement, but there was no bleb and it sloughed off, and the slow leak was noted from the thinned out scleral bed. There was a grade 1 shallow AC, fibrinous reaction in the AC. We waited for 2-3 days, and after that the AC shallowing increased, and it was IOP was not improving, so it was a glue BCL was planned for this patient. After glue BCL also, after 3-4 days when the situation didn't improve, the left eye corneoscleral patch graft with conjunctival autograft and AC deformation under general anesthesia was planned. This is 2 weeks after the corneal patch graft. The vision improved to 6/24. IOP was 22 mm of mercury with brimonidine and timolol twice daily. The fundus was stable. After 6 weeks, the vision improved to 6/12 and 8, and the IOP was well under control with 2 AGM. The gonioscopy showed the 360-degree peripheral anterior synechiae with scipedia in between. The fundus was stable, and the HVF showed tubular visual field, and he was asked to come after 2 months for review. After 2 months, the VGV dropped to 6/18, and the IOP spiked to 40 mm of mercury with that 2 AGMs. The anterior and posterior segments were as before. He developed cataract, and at that point, we started on the topical and oral carbonic anhydrase inhibitor, and he was planned for a phacoemulsification with IL implantation and AGV implantation. This is 6 weeks after the surgery. That VCV improved to 6/9 and 6. The IOP was 14 mm of mercury with timolol eye drop. Anterior posterior segment was as before. The AGV was placed at inferior temporal quadrant, and the tube was placed in the sulcus. He was advised to review after 2 months with HVF, and at next follow-up also, he was doing very well. So little bit about the bleb-related infection. It is the can be involve the only anterior segment when we call it as a blebitis, and when it involves the posterior segment also we call it bleb-related endophthalmitis. It can be early onset when it is happening within 1 month, and it can be a late onset if it is happening after years. The risk factor can be divided as bleb-related risk factor, ocular risk factors, and others. The bleb-related most common risk factors are the early, intermittent, and late onset bleb leaks. Intraoperative use of antimetabolized, which results in a thin walled avascular cystic blebs, nasal or inferior plus blebs, exposed suture ends both for releasables and the apical sutures, bleb needling and bleb remodeling, intermittent or chronic postoperative use of antibiotics, and increased axial length. The ocular risk factor may be increased epithelial drying, nasolacrimal drug obstruction, chronic bacterial blepharitis, the use of contaminated eye drops or bottle tip, and contact lens wear. The others may be immunocompromised conditions, diabetes mellitus, upper respiratory tract infection, and cold weather. The blebitis is an isolated bleb infection, the mild to moderate anterior segment inflammation without any vitreous involvement. The incidence is luckily quite less. It is 1.1 to 1.3% only. The common organisms are Staphylococcus epidermidis, Propionibacterium, Streptococcus, and Haemophilus. The symptoms are usually mild discomfort of foreign body sensation, the redness, watering, photophobia, blurring of vision. The signs are infiltrated opalescent filtering bleb that has a milky white appearance with loss of clarity. The conjunctival chemosis, intense conjunctival congestion, and ciliary injections localized around the bleb edge. There may or may not be mucopollulant discharge. The Sedal test may or may not be positive. The AC reaction may or may not be there. The posterior segment is usually within normal limit. The treatment is aggressive antibacterial therapy. The topical 4th generation fluoroquinolones and tobramycin with frequent instillation is started as primary empirical therapy. Topical fortified cefazolin can also be given. Topical steroids are started 24 to 48 hours after the antibiotics. Oral antibiotics can also be tried. Once the infection heals, active bleb leak should be managed. The prognosis is very favorable. The patient retaining relatively good visual acuity. Bleb-related endophthalmitis, the incidence is quite less. It is 0.1% for early and 0.2% for late endophthalmitis. The common organisms are Staph epidermidis, Propionibacterium, Streptococcus, and Haemophilus. The symptoms are reduction in vision, profuse redness and tearing, worsening pain and discharge, rapidly progressing deterioration of the clinical presentation. The signs are marked conjunctival hyperemia, anterior uveitis with increased AC reaction with or without hypopyon, white milky blood, positive sedal stress is very common, and vitreous involvement ranging from few vitreous cells to frank intravitreal abscess formation may be seen, and there is absence of red glow. The USG should be done to assess the posterior segment condition, and intravitreal antibiotics should be given immediately. Vitreous trap should be done, and topical antibiotics or fortified antibiotics are given for the as for the blebitis. Systemic antibiotics to continue, and early pars plana vitrectomy is recommended if not responding to intravitreal antibiotics. But unfortunately, the prognosis is usually poor. So precautions to be taken to prevent blood-related infection are the role of prophylactic use of topical antibiotics to prevent infection. It is questionable. And any conjunctivitis or blephariasis should be treated promptly. Patients should be educated about early symptoms of the infection. Bleb leaks are the predisposing factor of infection. Clinicians should look for the leaks during the follow-up visits and treat them immediately if present. Patients should be warned not to rub the eye with blebs and not to swim in water likely to be contaminated. These are my references. Thank you.
Very well managed case. I would like to ask you one question.
Sure.
How did you differentiate it in the first case, whether it is bleb-related endophthalmitis or just simple blebitis?
So in the first case, already initially it is only the conjunctivitis case. When the patient came, there was hypopia and there was no posterior view was not there, no glow, nothing is there already.
There was no glow.
There was no glow. The posterior segment, no view was there.
USG was done.
USG was done.
Okay, that shows the exudates.
There is done. The vitreous surgeons was managing that case, and first day they gave the injection, and the next day there was no improvement, and immediately they did the vitrectomy.
And second question is that how will you prevent the extensive leakage, bleb leakage? There are some techniques during surgery which can prevent bleb leakage in post-op period.
During at the time of the primary trabeculectomy, you are asking? Yeah. Oh, definitely. The dictum is whenever there is a leak, we have to close it on table. So, firstly,
no, I'm asking how to prevent it.
First and primary thing is handling the conjunctiva. Using the non-tooth forceps definitely is a very good. Round-bodied needles would be a very ideal in that condition. And whenever we are doing the dissection properly, we have to be extremely careful that there should not be a buttonholing, that part. That might help. And already, if it is a fornix-based, definitely there will be a possibility, the chances of leakage will be higher, definitely.
Yes.
But that we know already that the limbal-based blebs, already they give the ring of steel phenomenon that causes the more localized, and those that can also give the late onset bleb leakage.
Limbal-based, actually, they said to be it is means there is more incidence because of it is high bleb, thin bleb, and for prevention, I think you need to have for fornix-based. To extensive subconjunctival dissection, including a large area that will give a diffuse low bleb, which is less avascular. So I think that is the way to prevent as such. That is in our hand that we can do.
And also one thing that about the mitomycin C use, that is should be used at a minimum concentration and also in the diffuse area, more posterior area. We want the bleb should be there in the posterior segment, not near the limbus. So that area should be more diffuse area. There should be a low bleb, and that will definitely help to not to form the those cystic blebs in postoperative periods.
You want to ask one?
Us to examine the bleb area very carefully whenever a patient who has undergone trabeculectomy presents with a red eye. Like when the patient came, they diagnosed as conjunctivitis because Siddle's was negative. So in many cases, we can get a normal Siddle's negative, but we can do a forced Siddle's test. So whenever there is a red eye in a trabeculectomized patient, you gently put the fluorescent strip there and apply mild pressure inferiorly. And in many cases, there will be a very mild ooze that will be that we will be able to see. And if we can intervene at that point of time, maybe we can prevent the endophthalmitis and restrict it to the bleb only.
Another thing I usually want to mention,
because the safe surgical technique, because if we just make a very small frill in case of fornix based flap near the cornea, so that it will be much more fit tight. Otherwise there is a more chance if we just make a kind of the conjunctiva has been just overhanging this cornea, there is always been a chance of leaking. But if we just make a kind of a small frill just below above the cornea, so that will be much more airtight. That is called safe surgical technique. I mean, that has been documented.
We put a horizontal mattress suture also in that area. Yeah. Okay. So I'll proceed to my next talk now. This is a sponsored talk by Allergan, the safe sight years and quality of life. As you all know, the glaucoma is the second leading cause of blindness both in developed and developing country. This is a paper by Dr. Andre Hazel, which published in 2013, which showed that the cumulative incidence of blindness in at least one eye and bilateral blindness from glaucoma were 26.5% and 5% respectively after 10 years, which increased to 38.1% and 13.5% at 20 years. So in simple language, approximately 1 out of 6 glaucoma patients was bilaterally blind from glaucoma at the last visit, and median duration of bilateral blindness was only 2 years. So as clinician, we actually very much satisfied whenever we see the IOP is well under control, the visual field is stable, there is no much progression. But if we see from the patient perspective, we can see their concerns are far more important. The most frequent problems related to decreased vision were the reading, working on stairs, and recognizing people. Early detection of glaucoma, it is a vital objective to clinical management so that visual function and quality of life are preserved. Once in early damage in glaucoma, there may be difficulty in the driving. When in moderate glaucomatous damage, there may be history of frequent falls. And in advanced cases, there will be difficulty in reading. And in severe cases, there will be difficulty in orientation as well. So from the natural history of open-angle glaucoma, we have very limited data. Only the EMGT untreated arm and the CNTGS untreated arm gives some idea if a glaucoma patient is not treated, what happens to them. It is shown that the rate of progression is relatively less in normal tension glaucoma than the high tension glaucomas, and it is very much steep in case of pseudo-exfoliation glaucoma. So why it is important to know the rate of progression and glaucoma management? So it is very important that we immediately after the diagnosis, we should divide the patient whether the patient falls in the safe zone or unsafe zone to determine the risk of visual impairment initial treatment. I am coming to the safe and unsafe zone later. After diagnosis, we should collect the data to measure rate of progression, that is 3 fields per year during first 2 years. That is total 6 fields should be there in first 2 years. And after a couple of years, when we have estimated the rate of progression, we can apply this rate of progression in clinical management. So what is this safe and unsafe zone? This is the median line between this demarcation line, which represents the median rate of progression in a population-based study in Malmö, Sweden. And if it is showing that there are age and damage, glaucomatous damage is the most crucial point here, parameters to be taken care. If the patient is having younger patient, whoever has a early around 5 decibel of mean deviation, he falls under an unsafe zone, whereas an older patient with similar defect will be in a safer zone because the younger patient has longer life to live definitely, so more care should be taken in that part. And if a patient is same aged patient, whoever having the more glaucomatous damage will be divided in this safe and unsafe zone. And assessment after a few years, once we know the rate of progression, that time if the progression rate is somewhere around 0.6 decibel per year, we can maintain the therapy. If it is somewhere between the 0.6 to 1.5 decibel per year, we need to step up the treatment. And if it is somewhere more than 1.5 to 2 decibel per year, we need to radically change our treatment plan. So what kind of few extra millimeter IOP drop means to a patient? The various landmark studies have showed that if we reduce the IOP by 1 millimeter, there is a possibility we might reduce the risk of glaucoma progression by 10 to 13%. So how it is helpful for the patient? So if you take this example of a 60 years old patient who was diagnosed to have glaucoma with a mean deviation -5 decibel at the point of diagnosis, And if he progresses 0.6 decibel per year, so at the age of 77 years, his vision will reach almost minus 15 decibel, mean deviation will be reached. So if we reduce the IOP by around 30%, so 2 millimeter, by 2 millimeter, so 30% slower progression will be there. The patient may then reach the minus 15 by the age of 84 years. So like that, we will be able to save almost 7 sight years for this patient. As we all know this, the IOP reduction is the only modifiable risk factor. So we have the various classes of anti-glaucoma medications like prostaglandinic analogs, beta-adrenergic blockers, and so on. Recently, the ROCK inhibitors also. So I'll be discussing about the role of brimonidine in the IOP management. It is a selective alpha-2 adrenal receptor agonist. It's 1,000-fold selective for the alpha-2 adrenal receptor than the clonidine and apraclonidine. It acts by decreasing the aqueous humor production and increasing aqueous humor outflow through the uveoscleral pathway. The original formulation is the brimonidine 0.2% preserved with benzalkonium chloride, and the pH was 6.4, and now it is modified to brimonidine 0.1% preserved with purite, and pH is 7.7 now. It readily penetrates the cornea and results in a reduction of IOP within 1 hour. The peak effect is usually 2 to 3 hours, and the trough drug effect occurs 10 to 14 hours after instillation, and it has rapid metabolism and short half-life. Once we have compared this efficacy with the timolol, the efficacy was sustained over the long-term use, and after 4 years of treatment, brimonidine and timolol provided the comparable IOP lowering at both peak and the trough effect. It is a well-tolerated drug, and the ocular allergy with brimonidine was a little bit high. It is around 11.5%, but incident may have been overestimated. If you compare this with the dorzolamide also, the ocular stinging and burning sensation were more with the dorzolamide. The peak effect was almost similar, and the side effect profiles of dorzolamide and brimonidine is almost comparable, and their efficacy was comparable at trough effect also. So there are tolerability of the brimonidine part. There is, unlike the beta-adrenergic antagonist, it is not contraindicated in cardiopulmonary patients. It is safely and effectively used by patients with on systemic antihypertensive beta blocker therapy. In contrast to the prostaglandin analogs, it does not cause eyelash growth or pigmentation of the iris and eyelids. The common ocular side effects are conjunctival hyperemia, allergic conjunctivitis, and ocular pruritus. The systemic side effect, oral dryness and fatigue or drowsiness, can also be seen with brimonidine. The tolerability is the ocular surface is exposed to less drug once the concentration is reduced to 0.1%. The incidence of allergy is a very important factor to be considered when using the brimonidine. The risk of allergy is definitely higher with brimonidine, but the incidence may have been overestimated because the confusion of dry eye, seasonal allergic conjunctivitis, or bacterial conjunctivitis with drug-related ocular allergy. The allergic reaction may have several years to manifest, but the incidence of allergy is now less with the 0.1% formulation. The advantage, there are very advantages of brimonidine and timolol combination. Only the 0.2% brimonidine is approved by the US FDA. Definitely it's a time-tested molecule. Long-term IOP control is there. The less burning and stinging sensation with dorzolamide than dorzolamide and timolol. And it provides around 25% IOP reduction from timolol baseline and provides around 36% IOP reduction from PG analog baseline. So to summarize my talk, that is the glaucoma is commonest cause of irreversible blindness. There should be emphasis on the patient's quality of life. The progression is a rule. Even at the normal IOP, progression rates are highly variable and difficult to predict. We should incorporate rate of progression into our standard management. Safe sight years is important for maintaining patient's quality of life. We can have confidence when we deciding the further IOP lowering in patients who are progressing. We can use the extra power of drugs, fixed combination, and add-on therapies in patients who need further IOP reduction. Brimonidine remains an important part of the range of IOP reducing drugs. Thank you. Sir, only for normal tension glaucoma, it is separately. There will be, if a diagnosed case of glaucoma, that is a normal to have that almost around 0.6 to up to 1 decibel per year of that progression. It is normal. It is a normal course that this much of ganglion cell death will be there. So it is considered as this much progression will be there. If it's an accelerated progression is happening, then that time we need to change our treatment, and that's why this rate of progression analysis for every glaucoma patient is important. We never know who is progressing at what stage, how fast.
We also consider about what is the normal rate of, loss of nerve fiber. Is 5 to 6,000 nerve fibers are lost every year.
Yes, that's
so this is important in case of advanced cases of glaucoma, where it matters.
That is what I was asking.
Where it is matter.
This is, sir, I have shown in this this chart.
Probably 0.25% every year.
So this assessment after few years, once we have seen the rate of progression already, if innocuous progression will be there definitely. The innocuous progression, if it is there, up to 0.6 to up to 1 decibel per year, we don't need to change our treatment. We can maintain our therapy. And once it is around 0.6 to 1.5, then we might need to think that we might need to change our treatment in these patients. And if it is more than 1.5 to 2, then definitely we have to change our treatment.
And give the memento to Dr. Dipanshu Bosu Chaudhuri. Next, I would invite Dr. Debashish Chakraborty to please present the, Dr. Sumit Sil to please present the memento to Dr. Debashish Chakraborty or Dr. Surajit Sen. So our next session will be on retina. And chairpersons. Okay.
Thank you, everyone. It was a wonderful session. We have a lot of more interesting cases, so we are looking forward to it. So next session is on retina, and I'd like our chairperson to please come on the dais. Dr. Tebnath Chattopadhyay, Dr. Kajal Prasad Ghosh, Dr. P.N. Biswas, and Dr. Abhijit Ghosh. Please chair the session for us, sir. And as a panelist, we'd like to invite Dr. Shubijay Sinha, Dr. Pranab Das, Dr. Abhijit Chatterjee, and Dr. Anirban Chakraborty, sir. Sir, please come forward. So time is a challenge for us, so we'll just move ahead with the presentations. Our first presentation is by Dr. Sangeeta Roy. He's an eminent ophthalmologist, a veterinary surgeon in this city. He's the director of Global Eye Hospital. So over to you, madam. Ma'am will be presenting peripheral retinal degeneration management.
So I'll be going through the common peripheral retinal degenerations, and since a lot of PG students are here, I'll be explaining a little bit about each degenerations. So we can divide the different peripheral retinal degeneration into three parts: the vitreoretinal degenerations, the chorioretinal degenerations, and the intraretinal degenerations. So most commonly the structures that we see are of vitreoretinal degenerations like lattice degenerations, snail track degenerations, retinal tufts, and peripheral retinal breaks. Intraretinal degenerations are, we don't see that commonly, like senile retinoschisis or peripheral cystoid degeneration, or rather we can see most of the times we miss peripheral cystoid degenerations. White without pressure, definitely we see when we indent a patient, and I'll explain the structure separately. And chorioretinal degeneration is a paving stone degeneration, which we see pretty commonly. So this is a lattice So this is lattice degeneration. As you can see, there are crisscross lines in the periphery. Mainly they are present from the somewhere between extreme periphery and the equator. There are different types: intrabasal, juxtabasal, and you will be able to see crisscross lines in that particular. They are cigar shaped, and you can see crisscross lines. And sometimes you might see some holes within the lattice. And what is the basic anatomy of the lattices? There is a vitreous degeneration within the lattice, and there is a vitreous traction in the periphery. So what happens during a PVD induction, or if there is any kind of traction, there can be a tractional break, which is called HST, at the edge of the lattice, and since the vitreous overlying the lattice is liquefied, so it can cause to a localized RD. Now the lattices can be pigmented or non-pigmented, and there are few conditions like Stickler's syndrome, where the orientation of lattice is not the normal circumferential that we see commonly. It is a radial kind of lattice. Mostly it is seen perivascular, and I know literature says a different thing, but I generally treat these lattices, whether there is any symptom or not, whether there is any family history of retinal detachment or not. I generally treat these cases of Stickler syndrome at least with radial lattices. So the prevalence in myopes, it is highly prevalent. It is 33% in myope. In general population, it is around 6 to 10% of population. Although we see a lot of retinal detachment in which we see lattice as the cause of retinal detachment, which is around 20 to 30%. But if you consider as a whole, then lattices, the patients with, who are having lattices, less than 1% patients land up in clinical retinal detachment. So the incidence of retinal detachment in a case of lattice is not that very high. So when to treat a lattice? It is symptomatic lattice. Now, what is a symptomatic lattice? It is an acute onset of photopsia and floaters. Now, sometimes patients come and they tell us, I have a floater, 1 or 2 floater, and I have been seeing that for like 5-6 years. So that is not a symptomatic lattice. So symptomatic lattice means acute symptoms, acute onset of floaters, acute onset of photopsia, and in those cases, you have to treat those lattices. Symptomatic lattice with holes, same, you have to treat those lattices. And if there is a family history of retinal detachment in the other eye, initially it was like we were taught that if there is a history of retinal detachment in the other eye, you have to treat. But in the last slide, I will show that in AO preferred practice, they say that it is still debatable whether to treat these patients or not, when there is a retinal detachment in the other eye or not. I treat these patients. Snail track degenerations, basically you can see some frosted kind of appearance in the periphery. It is said that they are precursors of lattice degenerations only. And these patients, I think we can do annual review, they rarely need treatment. Retinal tufts, you can see a localized whitish kind of traction over the retina, like in the first picture. And this is in this particular paper, an OCT was done through that area, and there you can see there is a traction over the retina. And these retinal tufts can cause HSTs when there is a attempt to PVD induction. Peripheral retinal breaks, there are 3 types of breaks: atrophic holes, horseshoe tear, and operculated breaks. Now, what is the difference between an atrophic hole and a horseshoe tear? I'm sorry, I'm going into a basic here because there are many students here. Atrophic hole means there is a degeneration of the retina and there is a hole formation. And horseshoe tear means there is a traction over the retina and there is a tear. Operculated break means there is a traction of retina, it is causing a retinal break, and it is taking off a part of retina. So you can see an operculum over the break. There are many people here who are from my college. One of our professors used to say, holes means khich ke phatta hai, and breaks means holes means घिस के फटता है, and breaks means खिंच के फटता है. As if when you are tearing something, when you are pulling a traction over the retina, then it is causing a tear. Treatment: atrophic holes, of course, observation. And horseshoe tear, immediate laser has to be done. Operculated break, they say it can be observed because as the traction has already been removed from the break. So you can observe these patients. But practically, I would like to get an opinion from the audience that whether they would like to leave atrophic holes or operculated break with observation. I personally laser these structures. Peripheral retinoschisis, there is basically splitting of the neurosensory retina. It is also common in 2% to 7% of the general population. As you can see, this picture, as you can see, many people say that it is a retinal detachment, but it is not. As you can see, there is a bullous elevation of the retina, and there are no absolute holes. These are all thinning of the retina. Okay, so there is a bullous elevation of the retina, which is almost going towards the macula, but it is not an actual retinal detachment. Similar in this structure also. So these cases, they cause retinal detachment very rarely, and they have to be treated only when they are progressive. peripheral cystoid degeneration, there are microcysts in the periphery and they rarely cause retinal detachment. Generally, we follow up these cases. White without pressure. Now, what is white without pressure? Basically, there is a whitish discoloration in the periphery. You are seeing a retina, you are doing a good IO, and you can see peripherally there is a whitish kind of degeneration, and it seems to be a little bit elevated. So sometimes few people might confuse it with a retinal detachment, but it is actually not. It is actually a white without pressure. It doesn't need any treatment. It needs only observation once a year. And in few studies, it has been said that if there is a GRT in one eye and there is an extensive WWOP in the other eye, then a prophylactic encerclage might be considered. I have 2 slides only. White with pressure, it is when you are seeing a whitish discoloration in the peripheral retina with indentation, they don't cause RD. Paving stone degeneration is basically atrophy of the choroid and the retina in that area. So these are punched out round lesions in the retinal and with retinal and choroidal atrophy, and it mainly happens between the ora and equator. They don't cause RD, they don't need any treatment. So this is a slide which I was talking about. So acute symptomatic HST, it has to be treated. Acute symptomatic operculated breaks may be treated, may not be treated. Acute symptomatic dialysis, it has to be treated. Traumatic retinal breaks, we treat traumatic retinal breaks. Now asymptomatic HST, here it is said that we can go without treatment, but I will not leave a HST without treatment. Asymptomatic operculated breaks, treatment is rarely recommended. Asymptomatic atrophic round holes, again, treatment is rarely recommended. Asymptomatic lattice degeneration without holes, not treated unless PVD causes the HST. Asymptomatic lattice degeneration with holes usually does not require treatment. Asymptomatic dialysis, there is no consensus. And the last point where there is eye with atrophic hole, lattice degeneration, or asymptomatic HST where the fellow eye has had a RD, there is no consensus on the treatment. So in these cases, I would really like to have an opinion from the audience. Thank you.
Thank you, ma'am. It was a wonderful presentation. Lot to learn from you. I have one question.
Yes,
ma'am,
please.
if the patient would undergo some cataract surgery or is going for a YAG capsulotomy, and those cases asymptomatic lattice with holes.
YAG capsulotomy, I definitely do laser. Because it is said that after YAG capsulotomy, the incidence of RD is much more than an uneventful cataract surgery. It is almost equal to an eventful cataract surgery. It is around 5%, I guess, as far as I remember. So I would like to laser before a YAG cap. Cataract surgery, I don't do.
Madam, I will definitely not like my eye or my near and dear one having a horseshoe tear being left alone.
Yes, sir.
And to be observed.
Yes, sir, definitely.
Those are to be treated.
Yes, sir, definitely.
Excepting only the small asymptomatic holes.
Yes, sir.
Regarding the dialysis, you said that you won't treat.
That chart is AO preference practice guidelines.
That chart in that
preferred
chart.
AO preferred but what I said is I treat all lattices and I treat all HSTs, I treat all operculated breaks. And in atrophic holes, unless if the patient is cooperative, like above 10 or 12 years of age, I laser it, sir. I don't leave it like that.
Regarding dialysis.
Dialysis also I treat, sir. It has to be treated.
Yes, that is. I also like to treat.
It has to be treated.
So for the shortage of time, we'll move on to the next speaker, Dr. Arnab Das. He's a renowned retinologist. We all know him. He's from Disha. Sir will talk on management of diabetic macular edema. Over to you, sir.
Yeah. Good afternoon, all. Very big topic. Difficult to finish it in the time constraint, but trial. So we know for certain that DME management needs a wholesome approach, starting with control of blood sugar and blood pressure and also control of dyslipidemia. Studies have shown that early treatment with anti-VEGFs provide rapid visual acuity gains sustained over years. Intravitreal anti-VEGF injections along with good systemic control are the mainstay of treatment in DME, and in India these are the anti-VEGFs which are available as options. Amongst the initial pivotal studies was the RESTORE study, which compared 3 arms, ranibizumab with laser and laser alone, and it concluded that anti-VEGF ranibizumab was effective in improving and maintaining visual acuity and central retinal thickness with progressively decreasing number of injection over 3 years. Early starting of ranibizumab had an advantage. DME is a little bit more forgiving a disease than neovascular AMD. Thus, the laser arm in which anti-VEGF was permitted only from the second year too somewhat caught up, but not quite, as can be clearly seen here. Similar to RESTORE, the DRCR NET protocol I2 showed that early treatment with ranibizumab provides rapid visual acuity gain sustained up to 5 years. And as we know, DRCR NET had rigorous academic independence from pharmaceutical companies. So this is a study that we must all bank on and kind of follow wherever applicable. And the study again clearly showed the role of anti-VEGFs and was found to be much effective than laser and sham. And subsequent follow-up of ranibizumab groups in protocol I also demonstrated sustained improvement of mean and median vision up to 5 years, with a reduced treatment burden down to a median of 0 to 1 injection by the 4th and the 5th year of follow-up. And the best results were seen with ranibizumab with deferred laser in this. So both RESTORE and DRCR NET protocol I showed that fewer ranibizumab injections were required over time in DME. This is something that we should emphasize to our patients, will help them stay motivated and compliant, allowing them to keep hope that things will ease out with time. VIVID and VISTA trials assess the efficacy of aflibercept in DME, as we know. Rapid vision gains were achieved with early intensive aflibercept treatment in year 1 and were maintained over 3 years. And quite like the ranibizumab trials, fewer injections were required in the year 2 and 3. In this post-hoc analysis of VIVID VISTA, it again showed that those where aflibercept were started later didn't quite match up to those where aflibercept had been applied from the beginning. So this is what. And the large real-world global study, Luminous, clearly noted that better visual gains from baseline at month 12 was found in those treatment-naive DME patients who received loading dose than those who did not receive the loading dose. And study supports the fact that at least 5 or more injections are needed to achieve optimal visual acuity at the end of 1 year. So which anti-VEGF is better? DRCR NET protocol T looked into this aspect, and that time there was no brolucizumab, so that was not included. And when the vision was better than 20/50, the efficacy of all 3 anti-VEGF medications for DME was found to be similar. Although aflibercept was associated with rapid and greater drying effect than that was superior to those observed to both comparators at year 1, and so it was better than both brolucizumab as well as ranibizumab and maintained through year 2, with bevacizumab reducing the CST the least. So bevacizumab had a less drying effect. But does aflibercept perform better than ranibizumab and bevacizumab in patients with poor vision, that is eyes possibly associated with higher VEGF levels and more active retinopathy? Note this subset of patients with baseline visual acuity 20/50 or worse. Visual gains with aflibercept at year 1 was higher in the subgroup of patients with baseline visual acuity of 20/50 or worse. But what about the outcome at 5 years in patients with poor vision? Though there was a significant superior benefit to aflibercept over the others at year 1, in the second year the margin diminished, and there was no significant difference at 5 years in patients with even poor vision. So if aflibercept is superior to ranibizumab at 1 year but not so at second year and onwards, why should one consider aflibercept, which is supposedly costlier, instead of ranibizumab, which is cheaper for DME, even when the visual acuity is 20/50 or worse? Answer is found if one checks for the area under the curve. In patients with worse baseline visual acuity, the area under the curve was significantly greater with aflibercept than with either comparators over 2 years. Thus, EURETINA guidelines for DME understandably states that anti-VEGF treatment is recommended as first line in DME, and aflibercept is preferred in eyes with baseline visual acuity 20/50 or worse, as it works quicker, especially in this subset. But we know now from the Kestrel and Kite study that brolucizumab 6 mg was found to be non-inferior to aflibercept in DME in regards to functional improvement, with comparable proportion of patients gaining greater or equal to 15 letters. Also, more brolucizumab cases attain dry macula than aflibercept, with fewer patients on brolucizumab having residual subretinal fluid or intraretinal fluid. So it seems that brolucizumab also could be a logical choice in more severe DMEs and in some aspects even scores over aflibercept. How do you define persistent DME and chronic persistent DME? According to the Protocol I of DRCR NET guideline, persistent DME was defined as edema persisting at 6 months after initiation of anti-VEGF therapy, that is having received 4 or more loading doses, and chronic persistent DME was edema persisting beyond the first 6 months of treatment. One was at 6 months and chronic persistent was beyond 6 months. Protocol T showed us that amongst the eyes with persistent DME at week 24, which was least likely with aflibercept at 32% versus 66% with bevacizumab, continued anti-VEGF treatment of any kind decreased the probability of chronic persistent DME at year 2 even without switches. Similarly, this post hoc analysis of Protocol I, whose objective was to assess subsequent outcomes of eyes with DME persisting for 24 weeks after initiating treatment of ranibizumab, showed that the number of patients with persistent DME at 24 weeks who remained chronic persistent DME kept decreasing over time, down from 40% overall at 6 months to 16% at 3 years, in spite of no switching offered as per the protocol. But it will be nearly impossible to find a patient who will patiently and loyally allow a retinologist to continue with the same regimen, that is not trying something new for months together without finding significant anatomical or visual improvements. Also, among the 40% who have chronic persistent CIDME, it was noted that through the next 3 years, a lesser mean improvement of 7 letters was noted in those 40% where DME persisted chronically to 13 letters in those 60% where it dissolved. We know that although the main mechanism involved in the pathogenesis of diabetic retinopathy is VEGF upregulation, but in that inflammatory pathways may be at play too. So it is known that VEGF inhibition is not 100% effective in all patients. Despite 6 consecutive monthly injections of VEGF inhibitor, 40 to 60% of the eyes had persistent DME. This suggests that in some eyes, the main driver for DME is VEGF, whereas in others, pro-inflammatory cytokines predominate. And since corticosteroids have broad anti-inflammatory properties, it makes sense to use them in the management of DME in certain indications. What then is the right time to rethink on the treatment regimen? Post hoc analysis of Protocol T demonstrates the association of 12-week response in visual acuity with long-term vision outcomes. So at 12 weeks, there will be a group of good or elite responders with 10 or more ETDRS letter gain and a group of suboptimal responders with less than 5 ETDRS letter gain after 3 loading doses of anti-VEGF. It was seen that those with suboptimal improvements at 12 weeks had lower mean change in BCVA of only 6.2 letters at 2 years than those who had optimal response by week 12, that is 18.3 letters. Even studies on the outcome of ranibizumab in DME, the response at week 12 was found to be sustained up to 1 year and even 3 years. So response to anti-VEGF at 12 weeks is probably very important. A suboptimal early visual response at 12 weeks may predict a long-term suboptimal response and may help identify patients who benefit from an alternate regimen. So based on this concept, the generally accepted norm for switching since long has been patients doing suboptimally even after 3 loading doses, and as well as those who have not responded at all to 2 consecutive monthly injections of a particular anti-VEGF injection. So consider alternative anti-VEGFs or a trial of steroids in these patients. But should we wait for the second or the third injection, given that more and more useful intravitreal options keep arriving? In this Asian expert panel consensus for DME, where they defined inadequate response as where vision was less than 6/6 and the central macular thickness greater than 300 and change less than 10% after 1 to 3 anti-VEGF injections, they said that consider switching to alternate treatment modalities such as other anti-VEGFs or steroid. So even one might switch after one injection is what this expert panel told us. But which one to switch to between anti-VEGFs and steroids? If on OCT there are markers for good visual recovery, generally the acute cases will have these markers like spongiform DME, intact EZ, intact ALM, no SRF, no drill, standard or increased subfoveal thickness, but yet you are not getting adequate response with a particular anti-VEGF after 1 to 3 injection, would consider switching to another anti-VEGF over steroids. But if there are OCT markers for poor visual recovery or chronicity like chronic macular edema with large cysts, that 200 microns or more, associated with hyper-reflective signals within the cyst, absence of bridging processes between the cystic cavities, SRF, loss of EZ, ELM integrity, presence of drill, hyper-reflective spots, ORTs, early RM, then would switch to steroids rather than other anti-VEGFs or use steroid as an adjunct. Nearly finishing, this study compared the outcomes of continued anti-VEGF therapy versus DEX implant in eyes refracted after 3 initial anti-VEGF injections in the real world setting. And what they found is that those who were switched to DEX implant had better visual or anatomical outcomes at 12 months than those who had continued treatment with anti-VEGF for those diagnosed refractory after 3 anti-VEGF injections. So the same has been suggested by the Asian expert panel, where they define non-response as again vision less than 6/6, CMT greater than 300 and CMT change less than 10% after 3 injections, and they recommended that if no response, that is after 3 injections there has not been a response, consider switching to steroid, especially in cases of pseudophakic patients. So if one is switching to other anti-VEGFs, better to switch after the first or the second dose. If 3 doses of anti-VEGFs has already been received and yet inadequate response, better than to switch to steroids. And this is my last slide. Steroids is the primary treatment choice for DME in patients with recent history of CVA and myocardial infarction in pregnancy. When the nephrologists contraindicate the use of anti-VEGF injections in patients, patients scheduled to undergo cataract surgery and those who can't follow frequently, DEX implant is certainly the primary choice in DME in vitrectomized eyes. And additionally, DEX implant probably is more or most effective in DME with NSD in patients with chronic kidney disease, DME with significant heart exudates, and chronic DME especially, either alone or as a combination treatment. Thank you for a patient listening.
Thank you, sir. It was a wonderful presentation. So any question from?
In which of the treatment type patients you wish to start your treatment with Eylea?
As I said, I mean, those, of course, the patient has to afford, but that beyond, I mean, I would suggest the newer anti-VEGFs. I keep Eylea and Bolozumab nearly at the same platform. The advanced, I mean, the more severe diabetic macular edemas, there I would definitely suggest that the patient better off starts off with a newer anti-VEGF.
So the first choice, Bolozumab, you give patients in DME?
Yes. Initially there was the hesitance, plus there was that lack of approval. Now the approval has come not just from the US but also in India it's been approved. And our confidence has also grown. We have found Bolozumab to be safe and we know that it is effective in DME. Yes, but one difference of Bolozumab in DME versus Bolozumab in neovascular edema is that here you don't get that kind of a wow effect which you get in neovascular AMD. Here, I mean, it takes more time for things to dry up and improvements to come up.
And that too in a loading dose of 2 months interval.
Yeah, but the spacing is much more. I mean, for Bolozumab, I have a very simple thing. Like if somebody is resistant towards the loading dose, I might maybe consider Bolozumab, because some people say Bolozumab can be used as PRN, although I tend to promote Bolozumab even as a loading for DME. But importantly, patient doesn't want a monthly loading. They will say, I'll go for repeat injections, but if I have a better spacing. So that's one thing where the patient wants a greater spacing. Second, as I said, where I'm expecting this DME to be a bad one. It's like the vision is low, the CFT is high, it's a delayed treatment. The patient is beginning. It's although treatment naive, but you can see that the patient should have started or initiated treatment earlier. So these are my primary indications. And the secondary indications for brolucizumab today would be where there is a lot of fluctuations happening. Now there are enough studies to show that you have a patient responding to anti-VEGFs, but it's coming down and again it's bouncing back. So that these fluctuations on the long run result in poorer visual outcomes than in patients who don't have these kinds of fluctuations. So when I've started with something else and I find that it's working, but the fluctuations are happening quick and fast, then I would think of a longer anti-VEGF or a newer anti-VEGF, and brolucizumab comes handy there. And of course, where I need to switch. So these 4 indications where I use brolucizumab now.
Thank you, sir. Thank you so much. So I'll introduce our next speaker. He's Dr. Shoubhashree Sengupta. Is a prolific speaker, well-published ophthalmologist, founder, chief medical writer, lead biostatistician at Sengupta Research Academy. He has more than 100 publications and peer-reviewed journal on his name. So over to you, sir.
Thank you so much, and a very good afternoon to all of you. So before we head to lunch, and I think we have some more cases to go, first of all, a great presentation by Dr. Arnab. It will help me, I'll show you cases similar to what he has said. But before we go, I just wanted to ask, how is the Josh? I want to hear something. No, only 1 or 2 people are saying. How's the Josh at the back? Hi, sir. Super high. Come on, everybody. How's the Josh? All right. So I think I've already been introduced. So I just finished a stint as the associate editor of the IGO, and that was a very pleasurable experience. I have some financial disclosures, but there is no direct interest in any of the drugs that we will describe. So I thought I'll talk to you a little bit about biomarkers. So Dr. Arnab said that he will start it in a bad DME. So what really is a bad DME? And I'll show you some cases so that it sort of penetrates more into your minds. So these are some of the biomarkers. We all know these, right? So there is intraretinal fluid, there is subretinal fluid, there is the thickness that you can measure, hyperreflective foci and other things. All of these almost always coexist. You will almost never see one without the other. At least 2 or 3 of these coexist. Of course, that depends on the type of disease that you're seeing. However, which are the ones which are really influencing outcomes of VEGF management, isn't it? That is the one that we really want to think about. Because we all know that there is going to be thickness, and we all know that we're going to inject anti-VEGFs. But what the patient wants to know, and what you want to know even before you start, will he respond? Isn't it? Isn't that the most important question you want to decide? Will this guy have reduction in macular thickness? Or will I look like a fool at 1 month where it's the same thing all over again, right? So then how do you do that? So the 2 most important ones out of these are hyperreflective foci and RIL, that is disorganized inner retinal layers. So, when was hyperreflective foci first described in literature? It was in 2009, okay, and it was by a European group, and this is, so they had time domain OCTs, and it is best seen in black and white images, as you can see at the bottom. So it's best seen in black and white images and not in color images, and it can also be seen in time domain OCTs. Of course, it is seen better in spectral domain OCTs and the best in swept source OCTs. So this is from that original paper. Okay, so these are those hyperreflective foci. This is another slide from that same publication, which they clearly show how you differentiate it from hard exudates. Hard exudates look much larger, and hyperreflective foci are much smaller. And when you look at that same spot on the color fundus photo, you will see nothing. At the same topographic location, if you see those spots which are there, say superior temporal to the fovea, and you look at the fundus photo, you will see nothing really there, right? So hyperreflective foci are seen only on the OCT, while hard exudates are seen on the OCT as well. So there are much larger clumps. So as you can see, that red arrow there, that is hard exudate, and the smaller ones on the side are hyperreflective foci. Since 2009, a lot of study has been done to see, where they are actually influencing outcomes or not. And this, systematic review, which was published recently in 2022, it said that based on current literature, hyperreflective dots, numbers decrease with treatment, but it is not clear whether hyperreflective dots predict treatment outcomes in patients with DME. So they said it is not clear, right? However, when you look at that, that paper, so these are some of the studies which they have actually looked at. And the red arrow is really showing drop in vision, and green arrow is showing increased vision, and gray arrow is saying that vision will remain the same if you have hyperreflective foci at baseline. and the length of the arrow really is showing how long that patient was followed. So if you see, most of those are red. All of those are, at least majority of those are red. So it really means that if there is hyperreflective foci at baseline, it's a bad DME. Okay, so that means that the response or vision is likely to keep dropping. There is another new way of looking at OCT that is using artificial intelligence, and that entire thing which is evolving now is called radiomics. So radiomics is an AI-based machine learning kind of thing, and what it really means is that it's a way to look at subvisual features of these images. That is what the human eye cannot see. For example, turbidity of retinal fluid. How turbid is it? When you are looking at that cyst, is it a clear cyst or is it more turbid? So they say that if it's more heterogeneous in texture, there is higher VEGF load. So more turbid fluid, there is higher VEGF load, and also turbidity, that machine is looking at turbidity, but I think we are looking at the same thing from the human eye as hyperreflective foci. That is what I feel. But perhaps we should, take a look at these things. And this is the paper which actually looked at that. These are radiomics and images. Is published in 2023. So it's perhaps come into our practices by 2025, and some images of how they are doing it. So the verdict on hyperreflective foci is that it really indicates the bad DME, right? So this is chronicity in DME. It is associated with poor baseline vision. It is likely to predict slower resolution of DME, perhaps refractory DME, and it's preferable to start with agents which have stronger anti-VEGF, which are stronger anti-VEGF agents. The other one is drill. That is disorganization of the inner retinal layers. So this is the first paper which talked about drill, and this is in 2014, and this is from the DRCR network. And this is exactly from the paper, right, from the horse's mouth. This is what they said. So, I'm just trying to set straight what drill means. So first thing is you look only in the central 1 millimeter of that OCT image. And then, what you try to do is you try and trace these images, these layers of the OCT, the inner retinal layers. And once you come to within that central box, you will see that you're not able to trace them at all here. Well, here, even if there is fluid, you will see that you are able to trace these layers, above and below that fluid, right? So, and also the outer retina is, of course, traceable. So this is drill, where even if there is fluid, you will still be able to trace, those inner retinal layers above and below that fluid. And the original authors, what they said is that centrally located drill is correlated with visual acuity more than central retinal thickness, right? And both baseline drill extent and change in drill over time are associated with visual acuity. So if the drill is there, doesn't mean it's going to remain all the time. Similarly, if hyperreflective foci are there, doesn't mean it's going to remain all the time. But at baseline, they are harbingers of perhaps not such a great response. Right, so for HRF and drill, if they both are there, you need to discuss with the patient, tell them that this is like the bad DME. Reduction of HRF and drill also needs to be watched. After first injection, after second injection, what is happening to those? So you need to look at those topographically at the same cuts all the time. Start with perhaps aflibercept or brolucizumab in these patients because they are having more VEGF loads. And if you are starting with ranibizumab, think about switching quicker, maybe after the first injection. And perhaps, bevacizumab is not really a great option for these, for these kind of patients because the response is going to be even poorer. So let's take some examples of these. This is an example for DME. So I've put those, boxes on top. What are we looking for in these? So is there hyperreflective foci in this? Is there drill in this? And is there turbidity of fluid in this? As you can clearly see, you can trace those layers on top. Okay, some may say, oh, this is not much fluid. This is going to respond, you do whatever you want, right? So I'll show you some more examples, but let's keep this checklist in mind. If you look at that, you can't really see much of hyperreflective foci. There is definitely no drill, and the fluid in the center, that doesn't show a lot of turbidity, right? So there is none of these. All three are absent. So, there is good response, as you can see. So this patient had a loading dose of, so there is no HRF, there is no drill, there is good response. Patient was treated with ranibizumab. This is case 2. As you can see, there is massive edema, huge amount of edema, right? However, is there HRF? Perhaps there are few on top, we are not really sure, so much edema is there. There, as you can see, you can trace these layers even above and below that fluid. You can actually trace those even at the top, at the peak of that. So there is no drill here. And the turbidity, that fluid is also not as turbid. So again, there is response. Here I have used aflibercept because of the volume of the fluid and we want quicker drying. But then as you can see, immediately there is drying there, right? So there is massive edema, but there is no drill, there is no HRF, and there is response, right? So there is a good response here. Let's see the third example. There is not so much fluid, right? Like the previous case, not so much fluid. However, you can clearly see those starry sky, right? You can see those hyperreflective foci is relatively, it's all there. You know, if you trace these, you can't see, you know, even beyond the 1 millimeter, you can't really see any of the layers very clearly. You can't see the inner retinal layers very clearly. So the drill is there in the inner, you know, in the central 1 millimeter, but also around that. And the fluid definitely looks turbid, isn't it? If you see, you know, so if we call this non-turbid, then this, you know, so this is also relatively subjective, but hyperreflective foci is definitely, the drill is definitely there. Turbidity, you know, some may say it is and some may say it isn't, but hyperreflective foci generally will have this kind of, you know, turbid kind of fluid there. So here patient went ahead with aflibercept because I told them this is one of the bad DMEs. Despite a loading dose that of aflibercept, it has still persisted. The vision is still 6/36, right? So despite a loading dose, it has not responded enough. So, you know, this is sort of a checklist that you can use, and a lot of the times you will see that this is coming true. Let me show you two more cases. One is, both are of vein occlusion. This is a retinal vein occlusion, branch retinal vein occlusion. So this is an image at baseline. You know, very often when you have hemorrhages, there is a lot of shadowing below. So central 1 millimeter is very difficult to see, you know, whether there is drill and whether there is all of these or not. So a lot of the times you go ahead and you give whatever injection you think is appropriate, and at first visit when there is reduction in hemorrhages, reduction in the edema, that is when you might actually comment on this. So here, you know, we are not exactly able to see whether there is drill and whether there is hyperreflective foci right at baseline. So patient went ahead with ranibizumab, right? Because, you know, he said, oh, it's fine, you know, I'll go ahead with whatever is the cheapest. So, you know, these are, so again, if there were boxes on top, you would say there is no, likely to be no hyperreflective foci. Drill, I'm not so really sure. And, you know, turbidity is likely not there. You can see a large cyst in the center. So this is after one injection, you know, dramatic reduction. However, you know, there is definite edema here. You know, so I would like to see a show of hands as to how many of you would go ahead and inject again, and how many of you would say, oh, this is great, vision is 6/6 or 6/12, 6/9. I will not inject, I will wait and watch. So how many would you go and re-inject this? See, so this is at baseline. If you could see, you know, this edema is like massive edema, and I can't exactly see how, but it was really almost 600 microns. And this is after one injection. This is how BRVO, you know, most people who are treating, they'll agree that BRVO is the one which really responds like that dramatically. So will you re-inject again or not? Who will re-inject? Can I see a show of hands? Okay, there are 2 or 3. Who will not re-inject and say, it's all good, let's call the patient back again? There are show of hands again. Okay. So there are more show of hands here. And who are not sure? No, you can't get away without putting your hand up. You have to commit at least to one. I don't know, you can say, I don't know. So I want to see show of hands. At the back, no, none of you are responding. All right, okay. So, you know, if you don't re-inject here, it is going to just flare up again and again. Patient will come after 2 months and you will say, oh, yes, you need it. So this is PRN at baseline or loading dose without, you know, without any other considerations. That's what we are really discussing, isn't it? So if you do PRN at baseline for this, it will be never ending. It will be never ending. I'll tell you, patients will get 5 injections and at 1 year he will remain 636. If you go and re-inject here and if you give that loading dose, at 1 year, patient may still get 5 injections but will be 6/9. And I have at least too many examples to put up on stage. So loading dose, you know, that train is going to go, gaadi chhut gayi. If train is gone, that time is not going to come back. Monthly for 3 months is an absolute must. Only DME is one, maybe you could think about it, but still 70-80% will still need loading doses. RVO and CNV, you have to do loading dose, that is monthly for 3 months. Anyway, so then, you know, this was after the 3rd dose, and so it has again reduced some more. Patient is yet to come back. So this has responded to ranibizumab, and there were no hyperreflective foci, and there was, here you can clearly see there is no hyperreflective foci, there is no drill, there is no turbidity and all that. This is another patient I have seen I have seen a couple of days back. So is there hyperreflective foci here? Is there, yes or no? Even if you don't practice retina, you can clearly see it, no?
You can see those, right? Yeah, so there is hyperreflective foci very clearly. Is there drill here? Try and trace it from left to right. So your left to right, just try and trace those top layers. Are you able to trace it fully? No, there is a clear break, no there. Very clear break there is. So you're not able to trace them there. Can you trace something which is below the outer retinal layers? So So the outer retinal layers are also relatively not continuous. So a lot of people are now calling it DROL, DROL, that is disruption of the retinal outer layers. Okay, so there is definitely drill, there are hyperreflective foci here. So this patient, if you just go ahead and give an Avastin, the chances are that he is just going to keep coming back to you. Okay, even ranibizumab, that response may not be. So, just think of those checklists that I said. So based on these cases, basically the take-home message for DME and RVO is that, presence of HRF and drill is likely to be a harbinger of inadequate response. So choose stronger agents. So aflibercept and brolucizumab, perhaps at the same level, except for maybe 2-3 weeks extra duration of action. So Dr. Arnab has already told us that. So insist on loading dose in presence of HRF and drill. So these are the bad ones, right? So always insist on doing a loading dose for almost all, but for these you have to do it, and monitor reduction in HRF and drill with injections, and switch if that reduction is not happening. You may see a reduction in thickness, but that number of drill and that picture really looks the same. Most OCT machines have something called registration. So so when you scroll, they will show the same. So that is how you should look at OCTs. The previous OCT and the current OCT, and you keep scrolling the mouse and you will see the same cuts. Okay, so you can actually see that HRFs, at the same level every time. So if that HRFs are not reducing, if that drill is not reducing in its extent, some cuts of the central 1 millimeter, you may see there is not much drill. In some, you may see there is more drill, right? So just one image is sort of difficult to say, but if that is not reducing, then still think about switching. So this is really what I do. First thing I look at is not the amount of edema and not the thickness. First I look at is there HRF drill and is there turbid fluid? So is the IRF turbid? And this is mainly for DME and RVO, right? So if it is, then I always think about an aflibercept and now brolucizumab. Second thing I say, if there is none of these, then is the amount of fluid more? So 500 microns. So that's an arbitrary value that I've put 500 microns. But, 450 microns, 500 microns, it's a lot of edema there. If again there is a lot of edema, then again I'll think about aflibercept and brolucizumab and all those others which are remaining. So there is no HRF, there is no drill, fluid is less than 500 microns, like the first case that I showed you, right? So relatively innocuous looking case. There I would probably start with ranibizumab. So currently really in my practice, when I look at maybe the last 70-80 patients that have injected, more than 50% need to start with stronger drugs. And I think it's pretty much the same all across India, where patients don't come to us at that 612, 612, 618 vision that most clinical trials do. Most patients come to us at 636, 660, and they will have some of these features already. So, this is how I generally do it, and you will see that you will get much better responses. We keep crying, oh, clinical trial responses are never seen in our clinics, oh, our patients are not responding. But I'll tell you, there are very large organizations in India whose data I have seen and I'm privy to. Loading dose is done in only 10% out of 3,000 patients treated in a year. Loading dose was done in 10%, 300 out of 3,000. It was a study. So somebody came and said, a pharma company said, sir, this institution is ready for study. I said, okay, great. Then when we started cutting down, we found that actually we were able to get data for only 120 patients. Out of 3,000 treated, imagine that. Okay, so it's a large center which is, a lot of, so most of them were Avastin and other things. But what I'm trying to tell you is that loading dose is also not done. Right, so especially if loading dose is not done, you need to do something which is stronger and going to last longer. So Dr. Arnab has already really told us all of these, but I'm just showing you some cases just to drive home that point. So this is generally what I do in my practice. Just one slide on neovascular AMD and PCV. So in PCV, choose the strongest agent. The deeper the lesion, the better brolucizumab is. And it's even better than aflibercept for PCV. At least that's what I've been noticing since I've started using it. And then in PCV, we need to try to flatten that PED. You can see that very relatively large PED. We need to flatten that PED because that is where the pathology is, that's where the polyp is. And the brolucizumab monotherapy really works best is what I have seen, and I think a lot of our colleagues have presented everywhere. In neovascular AMD, we probably could start with ranibizumab, and loading doses is a must, and definitely not PRN. Switch when injection is too frequent or there is poor drying. These are things I think we already know. PD flattening really, doesn't happen with ranibizumab and Avastin, but then PD flattening is not totally our, what we are trying to achieve. We need to have the retina dry. Inner retina has to be totally dry. Outer retina, perhaps little fluid is okay. But, that PED is not going to entirely go away. So PED flattening is something that we are not looking for in neovascular AMD, but we are looking for that in PCV. So in these indications, again, these deeper and longer acting agents are better, especially in PCV, and almost half our patients in India are polypoidal choroidal vasculopathy, PCV. So, this is generally how I treat in my practice. So I'm happy to take any questions now or later. So I think the checklist is important. So is there hyperreflective foci? Is there drill? Is there turbidity? And I think that should be a good starting point.
Shobhushaji, thanks for driving in the point that loading doses are so very important, especially for RVO. Lots and lots of centers and lots of people do PRN. Right. We must all remember as retina practitioners that our goal is not just to reduce the edema, but to help the patient realize his or her maximum visual potential. Right. So without loading dose, that doesn't happen. Right. And secondly, we have to also alter the disease grade, the severity and the course. So that too doesn't happen without the loading doses. Right. So by not doing the loading dose, actually you are harming the patient's cause. It is as clear as that.
Absolutely. I think most of us who are treating more and more patients are realizing that more and more. And it was like, when I look at what I was doing in 2018, I still look back and see, wish I had done loading dose for this patient as well, and for that patient as well. So it's hindsight learning in addition to what clinical trials are saying. It's really a lot of hindsight learning also. A lot of us say, that company is pushing the drug, this and that. But the more you do what they're saying, the better that the outcomes and your patients get. So then there's no question about loading dose, at least in today's world. Yeah, it's a great question. So I'm finding it more and more hard to place Ozurdex in my practice now. That's because, so all of these are also indications for Ozurdex, right? So Ozurdex from baseline will keep needing injections again and again. There is no question about repeat injections. So, giving 3 Ozurdex, giving 4 Ozurdex, most of my patients land up in some or the other problem. So I've had people, of course, with raised intraocular pressure. I've had people with, reactivation of herpes. I've had patients with anterior viral uveitis. I have patients who have had retinal tears. So Ozurdex has its own set of issues, especially when you're considering the 4th or the 5th Ozurdex. It's a bit scary for us to do. So currently now with brolucizumab sort of having similar durations of actions, I'm finding it more and more hard to place Ozurdex in my practice.
For a disease which is driven by VEGF, corticosteroids can just have a helping hand, but cannot be the mainstay of treatment.
Right. So the main driver still is VEGF. Yes. Thank you so much.
Shobhushaji,
Thank you, sir.
Previously we used to do laser in case of BRVO. So now only VEGF treatment is going on. So how do you compare?
Yeah, that's a great question. So, nowadays we don't call it laser, we call it rescue laser. We've just renamed it. It's called rescue laser. So when you look at trials, even you look at protocol T and whatever we are using today, any idea how many % patients have required rescue laser over 2 years? 50% patients. The trial allowed you to do a laser if there is inadequate response after 6 months. That is after that 6 loading doses. 50% of patients, and all within 6 months to 12 months, have required rescue laser. So in DME, if you feel, I'm giving the best drug and still there is not enough drying in others, it makes sense to do a rescue macular grid or modified grid. In BRVO and CRVO, it's perhaps, they respond really well, sir. So then that suboptimal response is not seen provided patient is coming early. Even if they're coming late, BRVO really dries very well. So we don't think about doing any macular laser with BRVO. And in CRVO, that laser was really never an option, including from the CVOS study. So we are not doing much of macular lasers for RVOs. But for DME, I very much have it at the front of my mind that, this is something that I have trained for, and the current lot are not really comfortable doing macular lasers, but we are. So we should
just one point.
Yeah.
Even in RVOs, I mean, you want one day the edema to not come back, and by not coming back means that you don't need injections for at least 6 months.
Right.
The Horizon and Retain studies have said that 50% of RVOs don't need repeat injections by the end of the second year.
Yes.
And they have suggested that if you are not reaching that endpoint of not needing injections, in these patients you should think
Still
of
what?
adjunctive treatment. And by
Perhaps.
adjunctive treatment, it was laser,
Laser.
targeted laser,
Right.
or rescue laser, whatever you use the word.
Right. So then, yeah.
So even in RVO, there is a role for
There is
laser,
a
but
role.
not initially for sure.
Yeah.
Beyond 1 year.
Okay, thank you.
Thank you, sir. Thank you so
Thank you
much.
for a nice presentation.
So we'll hand over to the memento to Dr. Sangeeta Madam. Can you come on the stage? Dr. P.N. Bisha, sir. Please hand over to the memento. Sir. And thank you. Thank you so much. And we'll move on to the next session. I'll hand over the mic to Dr. Anirban Bhaduri, sir.
Good afternoon. This is the last session. I'm sorry to keep you away from your lunch. May I invite the chairpersons, Professor Anita Banerjee, Professor Ashim Kumar De, and Dr. Ashit Chakraborty to please come onto the dais. And I would request the panelists, Dr. Ayon Mohanto and Dr. Rudra Prasad Ghosh, to come and join me. And this is a very brief session on oculoplasty cases. You're ready?
Yeah.
Okay. So Dr. Dijan Wangdi Bhutia, she would be presenting a video on eyelid reconstruction.
Good afternoon, everyone. I'm Dr. Dishan Wongdi Bhutia from RIU Kolkata, second year PGT. The topic of discussion is bridge the gap near total upper eyelid reconstruction in a non-Agerian gentleman. A 91-year-old man presented in the OPD with a painless mass that was gradually growing in size in the upper lid with a dimension of 6.5 to 3.5 centimeter. It was discrete fungating ulcerated mass, firm in consistency, multilobulated, fixed to the tarsal plate, area of necrosis and hemorrhage could be seen. No transillumination defect was noted. This patient was planned for Cutler beard. Here we see the excision of mass that's being done, with extra 4 millimeter wide negative margin is being taken. After the excision of mass, it was seen that a near total upper eyelid defect was created with a dimension of 30 to 6 millimeter. A full thickness lower lid flap is being created currently, which is being taken under the bridge. Now there's a splitting of the anterior and posterior lamellae. At this current thing, it was seen that the lower eyelid bridge flap was inadequate, so 25% of the medial defect was planned by glabular flap. A glabular flap has been created. This is the rotation of the glabular flap under the bridge. Now there's a splitting of the anterior and the posterior lamella of the glabular flap that's being done here. Now the suturing of the posterior lamellae of the lower eyelid flap and the glabular flap is being done. And now the closure of the anterior lamella also is being done. Closure of the glabular wound is being done. So all in all, there was a glabular flap that was being done and a Cutler-Beard stage 1. Post-operative stage 1, the photo, and stage 2. There's a division of the lamella that's being done here. There's a formation of the upper eyelid margin. The preoperative finding, the postoperative, and the stage 2 postoperative finding is done. The postoperative eyelid movements, as we can see here. The limitation of this was intraoperative frozen section of the mask could not be done. Due to the old age of the patient, the tissue was very friable, hence a second bridge flap, the glabular flap was also planned. Postoperative edema of the Cutler-Beard could be seen. The take-home message is to identify early, excise completely, margin clearance is to be done. Thank you.
Thank you. Any questions for Dr. Bhutia? I'm requesting the chairpersons and panelists to put forward questions to her.
Ma'am, the full thickness, a defect. Yeah.
So how much gap was there?
Ma'am, 30 to 3.
More than 1/3 of the lid or 2/3 of the lid?
Ma'am, more than 2/3 of the lid. Almost a near total upper eyelid defect was created.
Almost total.
Mhm.
Then you have taken the flap from here, forehead.
Yes, ma'am, glabular flap.
Taken from here. And it should be the pedicular rest.
Yes.
Should be the pedicular rest. Okay.
Thank you, ma'am.
Okay, the next presenter is Dr. Yani Tripathi, who would be presenting. You have a question?
You have mentioned about the frozen section biopsy. Do you think that most, if available, most micrographic technique would be a better over to frozen section in delineating the normal and the abnormal tissue?
Ma'am, sir, I don't have much knowledge about the question that you asked, but I just have the knowledge about frozen section biopsy. So that was not available, so we could not close the thing and for the section to come out what it was a sebaceous gland carcinoma.
So what you are doing is not a paraoperative procedure. You send it and then you get the report.
Yes, sir.
Dr. Bhutia, shall I ask you a question? Since you don't have frozen section, would you want to wait for the permanent sections to come before you do the reconstruction?
Yes, sir, definitely.
So
we
was
would
the
wait.
reconstruction done on the same operative day as the excision, or was it done on a subsequent day?
So it was done on the same day of the operation. Since there was no frozen section available, so we kind of like, if it was available, we would have covered the wound for 2 to 3 days, and then we would have come back and done, reconstructed the eyelid as per the results.
Can we meet after lunch?
Yes, sir.
There are questions I need to ask you. Further
sir.
questions.
Yes, sir.
Good presentation. Dr. Yani Tripathi would be presenting a case of adenitis, right?
Good afternoon. I'm going to present a case of bilateral dacryoadenitis, the management pathway. A 46-year-old female comes with complaint of pain and swellings of both eyes since 20 days. More in right eye as compared to left eye. There is no significant systemic and past history. On examination, there is a firm tender lacrimal gland swelling and overlying erythema present. There is a mild temporal conjunctival congestion seen. On Hertel exophthalmometry taking base 95 mm, the right eye shows 21 mm and the left eye 19 mm. The Shermer one shows right eye 22 and left eye 16 mm, which reduced on Shermer's 2, that is 8 and 6 mm. Other clinical examination within normal limit. So the provisional diagnosis is bilateral subacute dacryoadenitis. The causes may be idiopathic orbital inflammation or some specific cause of the orbital inflammation, or it may be lacrimal gland tumor, may be lymphoma. So for the definitive diagnosis, we plan for incisional biopsy right side, and suggested investigations are hemogram with ESR, blood sugar level, test for sarcoidosis and Wegener's granulomatosis, chest X-ray, MRI orbit with contrast. Among them, the ESR is raised, which shows some inflammation is going on. So, and in the chest X-ray, there is a bilateral prominent bronchovascular marking and hilar congestion seen. In MRI orbit, there is a bilateral lacrimal gland hyperintense enhancement with spillage of inflammation in the surrounding muscle. Because presence of positive finding in chest X-ray, we advise HRCT thorax. In it, there is a right side patchy consolidation is seen. And the right eye biopsy was done and referred her to the pulmonologist. In the biopsy report shows there is a mixed lymphoplasmocytic infiltration seen, and there is a lymphoid follicle with prominent germinal center. And in immunohistochemistry, there is a IgG4 positive plasma cell seen. So the diagnosis was made bilateral chronic dacryoadenitis, IgG4 related orbital disease. In subsequent follow-up, the Shermer's test shows significant reduction, that is 1 mm and 0.3 mm. For the systemic evaluation, we suggested serum IgG and IgG4 level, and both of them are raised. After ruling out tuberculosis by bronchoalveolar lavage and clearance from pulmonologist, we started oral steroid 1 mg per kg per day and referred her to rheumatologist for other systemic evaluation. After starting steroid treatment, there is a significant improvement in the Shermer's test, that is 25 mm and 14 mm, and proptosis was also resolved. So IgG4 related disease are systemic syndrome characterized by elevated serum level of IgG4 and IgG4 positive lymphoplasmocytic infiltrative lesion in different parts of the body as seen in this picture. And orbital IgG4 related disease are 62% have bilateral one, and among them 69% have lacrimal gland involvement, which is most common. And there is a particular histology pattern seen. There is a different degree of lymphoplasmocytic infiltration with dominant sclerosing lesion or reactive lymphoid follicle. And in immunohistochemical analysis, the ratio of IgG4 plasma cells and IgG plasma cell is more important, and it should be more than 40%. The treatment includes systemic steroid radiotherapy or rituximab. So the conclusion of my case is, in history, the duration and laterality is important, because if it is acute, means less than a week, it is most probably the infective pathology, and if it is subacute or chronic, it may be because of some systemic inflammation or lacrimal gland tumor, and among them the systemic one is mostly bilateral. And in examination, in my case, the Shermer's test shows significant reduction. This shows there is just some inflammation going on in lacrimal gland. And the histology and systemic workup is the key for the diagnosis the disease. And in before starting steroid, we should done a proper workup, because it may regress the finding. Thank you.
Thank you, Dr. Yani. Any questions for Dr. Yani?
Hello. What is the follow-up?
So the patient, Yani, you should answer that question.
Sir, in last follow-up, the patient saw significant improvement, and we follow up for after 3 weeks. So the follow-up maybe in subsequent week she come.
So you have to follow it up because there may be a recurrence.
Yes, sir. Yes, sir. Yes, sir.
I'll answer that question. The patient is on follow-up. She is back for follow-up tomorrow again. She still has not seen a rheumatologist, but she has shown significant improvement with systemic steroids. See, the purpose of this presentation was that if you see what we call pseudotumor, you can treat it with steroids. But the problem is, you treat it with steroids, it will disappear. You will not know what is the pathology, because all so-called pseudotumors are not because of the same entity. And by hiding the disorder, you will actually be suppressing it for a time, and it will keep coming back. So biopsy is extremely important for patients with pseudotumors.
Thank you.
Thank you.
The next presenter is Dr. Manisha Agarwal is here. Dr. Manisha Agarwal is here. She hasn't come. Okay.
Good afternoon, everyone. I am Dr. Suman Sarkar, junior resident from Regional Institute of Ophthalmology, Kolkata. Here is going to present an atypical case of craniopharyngioma. Now, a 50-year-old male patient attended our OPD with chief complaint of headache for last 6 months and not being able to see anything over the right side for last 1 month. The headache was insidious in onset, dull and progressive in nature, and occurring once or twice weekly.
There is no significant past history. And in the treatment history, patient was treated by an alternate medicine practitioner outside and was put on eye drop timolol twice daily in both eyes for last 1 month. Coming to general and systemic examination, nothing significant was found. Coming to ocular examination, his best corrected visual acuity was 6/6 with adequate spectacle correction. Both eye color vision was normal. Extraocular movements were full and free in all directions of gaze. Both eye anterior chamber depth was normal with clear contents. No RAPD was found in both the pupils. And immature senile cataract of nuclear crevasses grade 1 was noted in both the lenses. Intraocular pressure was measured by Goldman applanation tonometry, and IOP was 14 mm of mercury in right eye and 12 mm of mercury in the left eye. Central corneal thickness was 494 and 498 micron respectively in both the eyes. An indirect gonioscopy was performed by 2-mirror gonio lens. An anterior chamber angle was noted wide open in both the eyes with structure visible up to ciliary body band in all the quadrants. And dilated fundoscopy examination was done, and vertical cup-disc ratio was found 0.6 with healthy neuroretinal rim in right eye, and temporal pallor was noted. And VCDR was 0.5 with healthy NRR in the left eye. Macula and periphery in the both eye were normal. Now a standard automated perimetry was done in Hamper field analyzer, and it shows right-sided homonymous hemianopia. Now, as the HA findings shows a non-glaucomatous optic atrophy suspected, so a MRI brain and orbit was done, and it showed a hyper-intense lesion in both the T1 and T2 weighted images in suprasellar area. So a provisional diagnosis of craniopharyngioma was made, as it is hyper-intense in the T1 weighted image. So it goes for the craniopharyngioma, suspected diagnosis. And coming to the treatment part, patient was taken off the anti-glaucoma medications and referred to neurosurgery department for further surgical management. Thank you.
Shuman, that was a very short and sweet presentation and a very nice finding that you showed. In a patient who has vision loss, is there something that you can do to pick up a field defect before you actually send the patient for perimetry?
Refraction, we can do.
For a field defect, is there some basic clinical examination that you can do to pick up a field defect?
We can check the direct and indirect light reflex. Field defect.
Okay, field defect. Field defect.
अच्छा, मतलब.
Somebody is answering from the audience for you.
Static, not static perimetry before dynamic perimetry to check the field defect.
Okay. One question for you. This was very interesting. I was observing that you can actually read all the plates of the Ishihara chart.
As isochromatic plate,
yes. That is surprising because most of us can't.
Most of us?
Most of us can't read all the plates of the Ishihara chart. The Ishihara chart is built. How many plates are there in the Ishihara chart? Color plates?
20 something.
So there are some plates that normal people cannot see. Which is why it is impossible for most normal people to be able to read all the plates in an Ishihara chart. But that is a very nice point that you made about examining fields in patients where you cannot explain the cause of vision loss. Any questions for Shuman?
One thing, craniopharyngiomas will usually not show homonymous hemianopia.
It will show bitemporal hemianopia,
but it starts from inferior and goes upward.
Yes, sir.
Okay, that is the usual representation. It depends on whether the chiasma is prefixed or post-fixed. That depends on that.
We suspect that
this is unusual. This is unusual type of fields.
Yes, sir.
Thank you.
It may be due to prefixed chiasma.
Confrontation. Nice presentation. Thank you.
Now I request Dr. Anirvan to take over.
There was a presentation on OSSN preceding this particular presentation, and I'm really missing the previous presentation. I wish Dr. Manisha was here, because this would have taken off from what she would have presented. So, this is supposed to be a 4-minute presentation, but please forgive me if I exceed time. This is a very good occasion to ask questions from all the PGTs who are present here. So, first question is, of course, you all know what is an OSSN. How many of you have seen an OSSN? Three, 4, 5, 6. Come on, yaar. How many of you have seen a CIN? Conjunctival intraepithelial neoplasia. So, people like us from the older generation, we were taught that there are CINs and CCINs, and we really didn't know. Okay, so some bright person, as a matter of fact, an extremely bright person decided to call all such lesions OSSNs, because it is impossible to clinically distinguish a dysplasia from an invasive squamous cell carcinoma. Clinically, they look the same. And we all know how OSSNs are treated, right? How many of you have treated OSSNs? Okay, how many of you know how to treat an OSSN? Go ahead. Tell us.
We start with the chief complaint of the patient. Then we go for the management purpose. In management, we start with the investigation. Investigation, anterior segment OCT. There is a hyper-reflective shadow of if the OSSN is there, and we see how much it is encroaching downwards, and it's encroaching towards the cornea or not. So we have to excise the OSSN part, and if it is very extensive, we can also give mitomycin over after dissection, we can also give mitomycin over that part, either in eye drop form or before closing the OT.
Okay, and this is what you've seen.
Yes.
And your name?
Sir, Anamika Paul.
Animaka, thank you. What is, in your opinion, the best way to treat OSSN? Suppose you don't have an ASOCT, what do you do?
Sir, we can also go for a biopsy, we can take the biopsy and then we can confirm it, and then we can go for the excision part.
Okay, and there is a role for UBM.
Yes, sir, UBM, yes, sir.
So my first question is, can you clinically diagnose an OSSN, or do you need to do a biopsy to prove it?
Sir?
The first question is, can you...
A feeder vessel.
So there are certain signs that you're going to look for, right?
Feeder vessel.
I think we'll have a class on OSSN after this gets over. Okay, I'll tell you the story of two OSSNs. Why these were basically to emphasize that you have a lot of options, and what treatment options you choose will depend on what you see. Okay, so we know OSSNs can be anything from dysplasia, where the basement membrane has not been breached, to squamous cell carcinoma, where the basement membrane has been breached. But we also know that OSSN can be very extensive, okay, where it can actually invade the globe, which is where the importance of UBM comes in, or it can even invade the orbit, where you can actually do a CT or an MRI to confirm whether there is orbital involvement. As Anamika, right, was saying, ASOCT helps us in knowing whether it has crossed the basement membrane. So the basic difference is, if it has crossed the basement membrane, you would go for surgery. If it does not cross the basement membrane, you can actually give topical chemotherapy. Okay, so what are the other choices? If it crosses boundaries, then you can go for surgery. Surgeries can even be destructive surgeries, or you can even go for radiotherapy. So I'll show you this lady, 60-year-old, who had redness, swelling and discomfort in the right eye for 2 years, and she's been seeing doctors. Her best corrected vision in the right eye was 6/12 and 6/9 part in the other eye, and she had multiple nodular masses, which was also involving the cornea. And you had extension of the disease here also. Do you need a biopsy to prove that this is an OSSN? Okay. So what happened is that because of this corneal involvement, we were under the impression that we would not be able to operate on this patient. This is inoperable in the sense that the only surgery I can do probably is destructive surgery. So how can I try to salvage the eye? We started the patient on chemo reduction with mitomycin C, not interferon. Interferon is the drug of choice, but we used mitomycin C deliberately because you want to rapidly reduce the size of the tumor. Okay, and this is after one cycle of chemotherapy. You can see that the major nodular lesions have regressed, but you can see nodules under the conjunctiva. Okay, look at the cornea, it looks moth-eaten, and you have nodules under the conjunctiva. Now that is a warning that you definitely have scleral invasion. This is exactly what we were suspecting when we started the patient on chemoreduction. And now we were in a position to do a UBM, and you can see the scleral invasion here. Okay? So this is not a patient where we can excise the tumor because the sclera is already invaded and I do not know the depth of invasion. So what other option do you have for treatment? So this is the patient where we decided not to do surgery. And we sent this patient for plaque brachytherapy, which is unfortunately not available in eastern part of India. This patient was treated with a ruthenium plaque, and this is the patient post-treatment. So the tumor has gone away completely. We now have 1.5 years of follow-up on this patient. She continues to have a residual opacity where the cornea had been involved by the tumor, but the patient enjoys good vision and she is safe. Okay, this is the post-treatment UBM that we have. Let's look at this patient. Now this also is an OSSN. Okay, this is scary because when she came in, we were not able to see the eye. But when we lifted up the eyelid, you could actually see a part of the cornea. The edge of the pupil was visible, and this is large mass which is protruding outside the conjunctival fissure, hanging outside the lids with an area of necrosis. What do we do here again? Can I do a UBM here? So this is a situation where I cannot do a UBM because I cannot put in the cup, right? So what we did was we got an MRI done, and we started the patient on chemoreduction while we were waiting for the MRI. And this is what the MRI showed. So you have this large mass here, but you can see intact sclera, you can see intact cornea. I don't know if there is microscopic involvement at this point in time. So what we did was we went ahead, did surgery. All right. After doing surgery, this is what we find. So surgery in OSSN is very important. You have to do a wide excision. If required, you'll have to do a lamellar sclerectomy, as we had to do here. You do alcohol keratectomy for the corneal side of the tumor, and you have to also do cryotherapy, which is done to the edge, or in this case, also to the base. So we reconstructed with AMG. This is how she is after she is healed. Again, she goes for plaque brachytherapy because the histopathology showed that she had scleral invasion. And this is the patient post-operatively. Okay, so basically the purpose was to say that there is a wide spectrum of disease and there are several treatment options. You can pick and choose which is the best for your patient. And if you don't have that facility, please don't be hesitant to refer the patient. So we have to send patients out of Bengal for plaque brachytherapy at this point in time, but that helps the patient. Thank you. Next week we have a program on oculoplasty, which is going to be held in the auditorium in Sushruth Hospital in Salt Lake, and I would welcome all of you to join us. One of the keys of this particular conference is going to be people from other disciplines outside ophthalmology who are going to be there. There's going to be a plastic surgeon, there'll be ENT surgeons. Okay, there'll be a radiologist who will be teaching us about CT scan and MRI of the orbit. And we also have maxillofacial surgeons who will be joining us. I'll welcome you all to come and join us. This is the link for registration, but we've already put it up in the OSWB group. And I'll request Dr. Devashish Boiragi to put it in the group that he has created for today's meeting, which was an excellent meeting. Thank you so much for your invitation.
Thank you, sir. There was a wonderful talk. Sir, please be on the stage. We'll hand over the memento. Ashwin Kumar De, sir, to please hand over the memento to sir. Dr. Rudra Prasad Ghosh. Dr. Anita Banerjee, to hand over the memento to Dr. Rudra Ghosh. I request our PGTs to please come forward. Sir, sir, And I request all the PGTs to be here who have presented. We'll hand over the certificates and a little memento. So please be there. And after that, you can proceed for lunch. I request the PGTs to come forward, please. Dr. Devaduti Chatterjee. Chatterjee. Dr. Shajol Golcha. এটা হয়ে গেছে সুমন সরকার হয়ে গেছে কি হয়ে গেছে সুমন সরকার হ্যাঁ অন করা আছে স্যার ডক্টর সঙ্গীতা সিএস Dr. Sepson Mohammed, please. Dr. Shubham Chaudhary. खड़ा हो जाओ. Dr. Shuman Sharkar. Dr. Shuman Sharkar. Okay.
You got the certificate, na? Great.
Dr. Yani Tripathi.
ओ इस पे तो नाम भी होमोनिमस है मेनू पे लिखा है इसमें आवाज आ रही है हेलो हेलो
Dr. Anjali. আর এই কোথায় সংযুক্তা কোথায় ডক্টর অশ্বিন গো পাঠিয়ে দিও আমারটা নিয়ে নিস ডক্টর সংযুক্তা তুমি মিলা नहीं डॉक्टर दीचन भुटिया Dr. Dichin, yeah. Dr. Sholil Nepal. Sholil Nepal. Oh. Dr. Shreyoshi Ghosh. Left. You can collect that. Yes, sir. Thank you, sir. Thank you, sir. At the onset, I'd like to thank OSWB for arranging with us such a beautiful event. Hopefully, you have enjoyed, you have learned from these sessions, and I think we will not wait for. We can go ahead with the lunch. Thank you, everyone. You can enjoy the video.